From the stresses of modern life to unexpected challenges, maintaining mental wellness is more crucial than ever. But who stands at the front lines of this battle for our mental health? Family doctors. They are not just medical professionals, they are guides, supporters, and pillars of strength for countless individuals and families. Join us as we explore the vital role of family doctors in nurturing mental resilience and ensuring a healthier, happier future for all. World Family Doctor Day 2025, Building Mental Resilience in a Changing World. Primary healthcare is uniquely positioned to promote mental wellness due to its emphasis on long-term relationships, continuity of care, and person, as well as patient-centered approaches. Life can be stressful and uncertain, with people everywhere struggling to cope with anxiety, depression, grief, and everyday pressures. Through early intervention, lifestyle medicine, and a holistic understanding of patients' lives, family doctors help people build resilience to manage mental health challenges before they become crises. Family doctors encourage adaptability, balance, and strength, guiding patients to find meaning and navigate life's difficulties effectively. By supporting patients in developing coping skills and promoting overall health, family doctors enable people to become resilient, better able to face life's ups and downs and enjoy a meaningful life. The most profound impact a family doctor can have on a struggling patient is to listen, deeply and without judgment. Acknowledging suffering is the first step towards healing. By offering empathetic and compassionate support and realistic hope, family doctors help their patients navigate difficult times and move toward recovery. We can distill the general practitioner's obligations down to two essential elements: to acknowledge suffering and to offer hope, as Prof. Christopher Dowrick says. Doctor well-being and patient care are intertwined. When family doctors prioritize their own mental health, they provide better care for patients, which in turn gives them a sense of purpose and fulfillment. This cycle ensures that both doctors and patients thrive together, creating a healthier and more resilient healthcare system. A thriving doctor means a thriving community. When family doctors are supported, their patients and communities benefit. WONCA, the World Organization of Family Doctors, fosters a global peer support network that strengthens the family medicine community, ensuring that doctors feel valued and connected, which ultimately enhances patient care and public health. Mental health is about resilience and adaptability, not a utopian ideal. Instead of pursuing the unrealistic goal of perfect mental health, family doctors focus on resilience, adaptability, and balance. This approach empowers patients to build skills and strengths that allow them to navigate challenges effectively, enhancing their overall quality of life. Credits: WONCA WFDD. In this final chapter, let's summarize the key points we've discussed and emphasize the pivotal role family doctors play in building mental resilience. Throughout this video, we've explored how mental health is about resilience and adaptability, rather than chasing an unattainable ideal of perfect mental health. Family doctors focus on empowering patients to develop skills and strengths that help them navigate life's challenges, ultimately enhancing their overall quality of life. Remember, mental wellness is not a destination, but a continuous journey. Here are some valuable resources and tips to help maintain mental wellness. 1. Regularly communicate with family and friends. Social support is crucial for mental health. 1. Physical activities can significantly boost your mood and overall mental well-being. 1. Practices like meditation and deep breathing can help reduce stress and improve mental clarity. 1. Don't hesitate to reach out to a family doctor or mental health professional when needed. They are there to support you. By incorporating these strategies into your daily life, you can build a strong foundation for mental resilience and well-being. Thank you for watching, and remember, family doctors are here to guide and support you every step of the way. In a
Good morning, all. A very, very good morning to all who have joined us this Sunday morning. On behalf of the Caribbean College of Family Physicians Jamaica chapter, the Association of General Practitioners Jamaica, and the Family Medicine Postgraduate Program, at the University of the West Indies, Mona Campus, Jamaica, let me welcome you all to the World Family Doctor Day Conference for 2025. As you saw in the video, the theme for World Family Doctor Day this year is building mental resilience in a changing world. And certainly that is something that we all have to do as family doctors. Whether we are a doctor in the public health sector, in one of the health centers, or a general practitioner or family physician in a private setting, it is our goal to help our patients to develop mental resilience, and certainly also to make sure that we do what is necessary that we too can have mental resilience. Within the ambit of World Family Doctor Day, our theme for our conference today is the impact of the aging population on primary health care. We are all very much aware of the demographic shifts that sees populations globally and certainly within the Caribbean aging and persons living longer. And we want to make sure that persons age as healthily as possible and enjoy optimal health. So without further ado, I do welcome you to what I know will be a rich exchange of ideas and interaction over the next few hours. To set the stage for this, I'm going to ask Dr. Andrea Purai, who is Vice President of CCFP Jamaica and the Chair of the World Family Doctor Day Committee for 2025, to lead us in prayer and to ask for guidance as we begin our seminar. Dr. Purai, over to you.
Thanks, Dr. Standard Golson. Let's bow our heads. Heavenly Father, we come before you with hearts full of gratitude and reverence, acknowledging you as the great physician, the source of all wisdom, healing, and compassion. On this World Family Doctor Day 2025, as we begin this sacred time of gathering, we thank you for your calling family doctors into a vocation of service, healing, and love. Thank you for the minds you have enlightened, the hands you have strengthened, and the hearts you have filled with compassion to care for your children in every corner of the world. Lord, we ask you for your divine presence to guide this virtual conference. May your Holy Spirit fill this place and direct every discussion, every presentation, and every decision made. Let this be a time of inspiration, unity, and renewal for all who have dedicated their life to family medicine. We pray for the presenters, attendees, drug companies, sponsors, committee members, Secretary Ms. Lynn, IT personnel, Mr. Harmon, Mr. Harold Sam, who made this conference possible. Grant them the endurance to continue in their noble mission, especially in the places of their great needs and hardship. May they see you, your face in every patient they serve, and their work bringing glory to your name. May this gathering lead to new ideas, partnership, and solutions that reflect your love, mercy, and justice. As we go forth from this conference, may we do so with renewed sense of calling, to serve with humility, to teach with truth, and to heal with grace. And may your peace, which surpasses all understanding, guard our heart and mind in Jesus Christ. In Jesus' name we pray. Amen.
Amen. Thank you very much, Dr. Purai. I'm now going to call on the president of CCFP Jamaica, representing CCFP Jamaica, AGP, and the Family Medicine Program, to do the formal greetings and welcome Dr. Seni Hananushu.
Good morning, everyone. To our specially invited guests, Professors Marvin Reed, Karen Carpenter, and Denise Eldemeyer Shearer, Doctors Victor Elliott, Mark Hossan, Kian Bukal, Salvatore Ferraro, Tamu Davidson, Ovil Nemhard, Gat Ratri, Anna J. Brown Morgan, and Ista Gubaya. Moderators, Professor Monica Asnani, Doctors Ellen Standard Bosin, Olive William Green, esteemed colleagues, administrative staff of the college, headed by Mrs. Lynn Thompson Hyatt, IT support personnel, Mr. Samuel Heron of Oldgate Solutions, sponsors, all attendees, friends, ladies and gentlemen. A pleasant good morning to you all. On behalf of the World Family Doctor Day Planning Committee, comprised of Caribbean College of Family Physicians, Jamaican Chapter, Association of General Practitioners of Jamaica, postgraduate family medicine students of the University of the West Indies, Monarch Campus. The theme of this morning's presentation is the impacts of the aging population on primary healthcare, and it is indeed a timely one. Aging is without a doubt one of the inescapable realities of life. As we age, we are confronted with a decline in our health status, which is often associated with multiple morbidities. Although we cannot completely eliminate these morbidities, we can certainly prepare for them and manage them by equipping our doctors and all healthcare professionals with the knowledge and tools to manage age-related conditions, effectively promote healthy aging, and optimize chronic disease care. It is hoped that today's deliberations will enhance awareness of geriatric syndromes, improve multidisciplinary care approaches, address mental health in older adults, and explore innovations in community-based support systems through the use of multidisciplinary approaches. To this end, we have various topics focusing on the older adults, such as malnutrition, sexual health and relationship dynamics, cardiovascular complications and management, violence, injury and abuse, provision of care for adult persons living with physical disability and their challenges, which will also be brought into focus, along with the importance of adult vaccination and strategies for building mental resilience in a changing world. A panel discussion on public-private partnership in healthcare, exploring collaborative approaches between the Ministry of Health and Wellness and the private public health system, will be discussed. As such, we have a lineup of well-accomplished speakers and panelists to share their knowledge and insights with us today. Please join me in wholeheartedly welcoming them all. A special welcome to all our local, regional, and international members and attendees who continue to support us. I wish to recognize the World Family Doctor Day special awardees this year, and these are Doctors Brad Pat, Owen James, and Jerome Stern. We congratulate them. Also, the MAJ awardees for 2025 are Dr. Anna J. Brown Morgan and Dr. Gat Ratri. In 2024, there were Doctors Jennifer Bent and Seni Ononuju. Thanks to Medical Association of Jamaica under the leadership of Dr. Leslie May for including the family doctors in their list of awardees since 2024. We also thank Mrs. Christian of CariMed and CariMed for consistently supplying us with tokens of appreciation, which they have been doing for over a decade. Annually, for the past 10 years, in commemoration of World Family Doctor Day, the committee identifies and lends its support to a special outreach project. This year, the Community-Based Rehabilitation Jamaica CBRJ project was chosen. Its head office, based in Spanish Town, works with several hundred disabled children island-wide and hosts visiting eye doctors and other physical therapy groups from North America every year. World Family Doctor Day Committee assisted in keeping them operative by way of donation towards the renovation of their kitchen and bathrooms. More funds are needed for the completion of the renovations, and we are therefore appealing to those colleagues who are able and willing to reach out to them with any donations they can afford. On behalf of the World Family Doctor Day Planning Committee, I thank and welcome you all, and I invite you to sit back and enjoy the presentations. Thank you, and God's richest blessings.
Thank you very much, Dr. Seni. And without further ado, we are going to jump right into the meat of the matter for today, the first of our presentations. This presenter really needs no introduction, but I still will remind us all of the credentials of Professor Marvin Reed, who is the current Deputy Dean of Research in the Faculty of Medical Sciences at the University of the West Indies, Mona, a past director of the Tropical Metabolism Research Unit, Caribbean Institute of Health Research, and an associate lecturer in the Department of Community Health and Psychiatry at the University of the West Indies, Mona. His research interests span the gamut of community medicine, clinical trials, and human metabolism. He has co-authored over 140 peer-reviewed articles and has received the Mona Campus Principals and the UWI Vice Chancellor Award for Research Excellence, as well as other international awards for research publications. Professor Reed practices as a family physician in a group practice and is a member of the Family Medicine Specialty Board at the UWI, which advises on postgraduate family medicine training. He is a member of several national, regional, and international professional bodies, such as the World Organization of Family Doctors, WONCA, the Medical Association of Jamaica, the American Physiological Society, as well as a member of the Research Advisory Committee of the Caribbean Public Health Agency. He is a past president of WONCA North America, current president of the Caribbean College of Family Physicians Regional, and president-elect of the Medical Association of Jamaica. It gives me great pleasure to welcome Professor Reed to speak to us on malnutrition in the aging population. Prof. Reed.
Thanks, Eileen, for that kind introduction. So, colleagues, we're going to try and see to be as efficient as we can with time. So, again, it's my pleasure to present on a topic that is very dear to my heart. Having spent a considerable amount of my career, professional career, at the Tropical Metabolism Research Unit, which is a clinical nutrition unit. So in starting, just want to highlight some possible areas of conflict. As many of you may know, I'm a Grace Kennedy scholar. Grace Kennedy is one of the big food establishment, global food establishment within the Jamaican sphere, and I delivered the 2016 Griskin the annual lecture. Similarly, I was sponsored by Abbott Nutrition to do the Pediatric Total Nutrition Therapy course, which is a trainer course to teach individuals how to support children with bionutrition. That took place in Chicago. And although I have no plane to show for it, they actually put me up in the Trump Plaza, but that's another story. I've also used Nestle's nutritional product for a lot of my research, nutritional related research. I just wanted to just highlight those issues. The objectives of my talk today is really just to say, as I always do, to start about what we call, or what I call, principles of human nutrition. When we're speaking somewhat on malnutrition, give you a rough idea of the prevalence of malnutrition just based on some data from the Jamaica Health and Lifestyle Survey 3, talk about sarcopenia and frailty, and some possible interventions. So what do we mean by the principles of human nutrition? Well, human nutrition is one of those areas in which there are many experts. I often ask my students how many nutritional experts there are in Jamaica. Most of them always get it wrong. But the truth be told, nutrition is something that all of us as individuals have to interface in for our own survival and existence. And therefore, in some ways and shape and form, many of us consider ourselves knowledgeable about nutrition. So the answer to that question is really the number of cognitively normal individuals in Jamaica would be the number of nutritional experts we have. There are lots of sources of nutritional information on the web, in books, and nutrition is one of those things that I sometimes equate it to religion, because individuals pretend or utilize it almost on a belief kind of a structure rather than being informed by science. So as a consequence, I always like to start by just defining the language for what we use, what we mean, and then proceeding in the rest of the talk. For me, human nutrition represents the interface between your food intake, whatever it is that goes into your body, and what we call your metabolic demand. Anything that modulates that interaction really comes under the ambient of human nutrition. So within that constraint, or within that construct, we have that human nutrition represents the cyclical issues of intrinsic factors and environmental factors. Under the intrinsic factors, we have things that your total genes that you have, how those genes are expressed throughout your life course, where you are in terms of your life course, your mood, issues related to your appetite and dysregulation of your appetite, your lifestyle, what it is that you do. We recognize as well that we exist in a symbiotic relationship with microorganisms, and therefore the level and the perturbations that may occur in that symbiosis will also be modulated by nutrition, and in turn will influence your nutrition. And of course, your disease state. Do you have cancer? Do you have any other inflammatory disease? We also recognize that there are many cultural interactions. Your beliefs. Do you like certain foods just because of your religious belief, your culture? What are the things that as a society, as a group that you do? Issues related to food security and access, economics, social circumstances. How is food prepared? Nowadays, we have to think about climate change. And importantly, we have to think about policies, whether at a national level, regional level, or international level. All of these factors will impact to a large extent your nutrition. When we look at your food intake, we talk about your diet and what does your diet consist of. Essentially, some nutrients that is important for your body metabolism, carbohydrates, lipid, vitamins, minerals, and trace elements. But they may also contain other compounds that we may add as we prepare our diet. Some of these additives are purposeful, some of them are inadvertent, and some of them will have adverse or detrimental health effects. But what does a diet do? A diet really provides us two main functions. One, it acts as a fuel. So it provides the cells, the organs in the body, the energy that it requires in order for survival. Additionally, the other important constraint of the diet is that it provides specific nutrients that are responsible or engage in specific chemical reactions that are necessary for life. An important conceptual consideration when we think about the diet is this whole concept of what we call turnover, because the body is not in a static process. It is in a constant state of building and breakdown. So that constant state of building up and breaking down is what we refer to as turnover. And it's a very important concept because it allows the body to adapt to perturbations in its environment in a fairly efficient manner. Importantly, as we think about nutrition, we think about the interactions that it has in terms of the human body, more and more, many of us have come into the conclusion that nutrition is a demand-led process and not a dietary-led process. And what do we mean by that? Well, first thing we have to understand, what is your metabolic demand? What are the components of your metabolic demands? Those components are really two things. One is what we call your basal component, which is the amount of energy that you really need at basic rest to be alive. And so technically we define that as the amount of energy required to maintain homeostasis or balance. And we actually measure this usually after a 12-hour fast in the morning. And here on the picture on the left, you see we're doing metabolic measurement on a patient at the TMRU. Then you have on the right what we call the variable component, which will consist of the amount of energy that is required to process your dietary intake. Some of us call it the thermogenic effect of food, physical activity, maintaining our body temperature, which is very important in the very small infants, especially if they're premature, and certainly when we're in the growth phase of our life for growth. So one of the important things is that the diet has to match the demand, and certain conceptual things happen. That matching has to occur where there's an adequate supply of nutrients at the right place, the right time, and in adequate amounts. If any of the three conditionalities are breached, we will end up with a mismatch. So you can have quite a lot of food, but if it's not where the organ or the cells need it at the right time, in the right place, then clearly you're going to have a problem. A fundamental nutritional concept, if that is, there is a mismatch between supply and demand, there always is, always will be an alteration in both the form, which is really just the structure of the organ or the cell, as well as in terms of their function. So how do we go about satisfying this demand? Well, demand is a continuous process, which basically means that throughout a 24-hour cycle, you always will have demand. But many of us don't eat continuously. We eat intermittently, every 6 hours for some. If you're a poor lecturer like myself, then probably once a day. But the long and short is that diet is intermittent. So what's the consequence of that? It means, therefore, that in order to satisfy your demand, the first port of call is always going to be from your basic body. And when we actually eat, all that we're doing is replenishing those body stores. So we recognize that whenever there's a mismatch between the supply and demand, as I said in the previous slide, there's always going to be an alteration in form and function. So those alteration in form and function comes to us as what we call a functional cost. So essentially then, malnutrition just represents a change or alterations in the form and function because there's a mismatch between your intake and your demand. Come 2016 thereabout, the leaders of the various nutritional society, ASPEN, the American Society of Parental and Enteral Nutrition, ESPEN, and the Asian group, as well as the Latin American group, they came together to develop what would they consider to be a global consideration or definition of malnutrition that could be used primarily in the adult patient. And what they came about was that essentially we should encourage healthcare professionals to actually screen for malnutrition. And those screenings should actually be done using specific tools we call validated screening tools. And they accepted that there are two main components to that assessment. Remember, I said there's alteration in form and there's alteration in function. And therefore, when we look at the assessment criteria, we define a phenotypic component, which will look at a change in form, which is primarily weight loss, low body mass index, and reduced muscle mass. And then we look at function. Are there any issues that is related to the assimilation of food? Are there any major disease burdens? Once it is that we have made the diagnosis of malnutrition, which for standardization and research process globally, we said should contain at least one phenotypic criterion, one etiological criteria. We then move into grading the severity. And then once we have graded the severity, we then tailor our intervention accordingly. What are some of the screening tools that are promoted? The one I normally train my students on is really the MUST training tool, which is a malnutrition universal screening tool that can be used basically in communities based on your BMI, based on whether or not you've lost weight recently, and whether or not you're likely to continue to eat. There's a nutritional risk screening tool, which was developed by ESPEN, primarily used for patients who are going to be in a hospital scenario. But for the purposes of this talk, since we're focusing on the aging, I'm going to be spending some time looking at the mini nutritional assessment short form, which was developed by the Nestles Institute. And it's a form that we can actually use in our practice because it's a relatively easy form. It has 6 questions, which speaks to about your food intake, which speak to whether or not you've had weight loss within the last 3 months, which speaks to issues related to mobility, as well as issues related to an anthropometric measurement, which looks at your body mass index or your calf circumference if you're lying in bed. So essentially then, what we then say then is that we define your nutritional status, as I said, based on a phenotypic score and based on an etiological score. And on the phenotypic score, we have defined criteria for weight loss. We have defined criteria for your BMI. And we also look at whether or not we can measure your muscle mass. Now, why has muscle mass emerged as such an important consideration? That is because we have developed or have identified that there's a specific issue with the gradual loss of muscle mass as we age. That condition is what we call sarcopenia, which I'll discuss in some further details in subsequent slides. On the slides at the bottom row, you'll see that I've put in there some pictures of some common equipment that we can invest in our practice to ensure that we can do some degree of an assessment. So it's an anthropometric tape or tape measure. To the right of that is a BIA instrument. There are many of them now on the market. Some of them are just like a regular scale. They can give you a relative index of your fat mass or fat-free mass, a stadiometer to measure your height, and of course a regular scale. So in order to get an idea of the degree of the burden of the disease, really, one of the things I did was to really just to look at the Jamaica Health and Lifestyle Survey, which is a national representative survey that we do every 5 or 6 years or so in Jamaica, and assess the levels of issues related to like chronic diseases, nutritional status of our patients, and certain as we think about mental health, also get some measure of the mental health. What I've done here is on the left, I've actually, this is a survey conducted between 15 years old individuals over 75. What I've done is really just to put what the BMI criteria is. So remember when we looked at the malnutrition, we said BMI is one of those things that we could use. So this is a cross-sectional static representation. And what we see is that roughly as individuals get older, as we move from left to right on the left graph, line graph, we see that on an average, the BMI undernourished category, which is less than 18.5 kilograms per meter squared, is roughly over and at about 10%. We recognize that the upper 2 lines, which is the yellow and the green lines, represents overnutrition. So those that are overweight and in the obese category, you see that as we age, moving from the 15 to the 45 to 54, there is an increase in the prevalence of those individuals who are overweight. So if we look to the right now, look at the nutritional state by age group category, so those are the stacked bar curves to the right, we recognize that the poor nutritional ones, which are the bottom purplish looking color, I'm hoping that you can see it's purple, you see that the prevalence of poor nutrition actually is fairly high in the Jamaican context. So roughly, if we look at the 55 to the 75 age group, roughly 30 to 40% of individuals will be considered to have normal nutritional status, and roughly 60% and above would have what we call poor nutritional status. Either it is by BMI category, they're undernourished, or they're overweight and obese. So it means, therefore, that poor nutrition is actually a significant public health burden within the Jamaican context. I just want us to turn our attention quickly to the whole concept of frailty, which is a clinical recognized challenge that we will have that increases the vulnerability of our aging population. And it's really just a state in which individuals through to age undergoes age decline in their reserves and function. And it's really due to multiple physiological systems decreasing in terms of their reserve capacity. And therefore, it means that any little stress can actually tip them over. And therefore, there's an increase in terms of morbidity and mortality associated with it. So on the graph on my right, the pictorial diagram on my right, what we said is that there are many factors that influence this concept or this construct. One is that you have the genetic factors and environmental factors, but ultimately, when you look at the physiological reserve, all the systems that we can think about decreases in function. Now, one of the considerations here on the right-hand side, you see I speak about nutritional factors. And the key component of that nutritional factor that I want to speak to you about is this whole concept of sarcopenia, which is now recognized by ICD-10 as a specific disease category that can be coded. And what happens is sarcopenia represents both a decline in the mass as well as a decline in the function. There's impaired strength. And we, as I said in the previous slide, these things or these nutritional factors can affect or contribute to frailty and some degree of disability. Now, although we conceptually accept that, there's still some debate as to how best we can actually diagnose this. And so for the purposes of our discussion, we will look at the two main common groups that we use. So there's the European Working Group on Sarcopenia, and there's the International Consensus for the Society on Sarcopenia on Aging. So when we look at it, one of the things that we normally would do, and this is something that we can actually do in our practice, is that we can screen for sarcopenia. And one of the tools that we use is a tool called this SAR-F screening tool, where the S is for strength, in which we'll ask our individual how much difficulty they have lifting or carrying 4.5 kg or 10 pounds. And we score that, how difficult they have in terms of walking across a room, how much difficulty do they have rising from a chair, climbing the stairs, or how many falls they have had within the past year. Each of these components are then given a score, and then based on that score, we will then suggest that it's possible that they may have sarcopenia. So if it is that we use the screening tool and we find that there's a possibility that they may have sarcopenia, the next part of it is to do their muscle strength assessment, which is normally done by a grip test. And then if that is low, we then say that, okay, they're probably sarcopenic, and then we then assess their muscle mass. And assessing muscle mass can be done using some of the techniques I mentioned earlier. The gold standard is to use a DEXA. So at TMRU, we actually do use a DEXA to measure that. But you can also get some idea using a bioelectrical impedance or BIA, as well as dilution methods, CT scans, and MRI. Once it is that we have identified that the sarcopenia is there, the next part about it is really just to assess the severity of sarcopenia. Now, one of the things that we wanted to do was really to see whether different methods of assessing a muscle mass made any difference within the context of the Jamaican scenario. And several years ago, one of our PhD students, Dr. Bentley Chambers, embarked on such a study where we looked at the different techniques, DEXA, D2O dilution, which is deuterium water dilution, BIA, to assess whether or not there were differences in fat-free mass, assessing these techniques. So we could make recommendations to the Jamaican health community as to which methods were acceptable. The truth be told is that both methods, all the methods that we assessed, gave relatively similar results for the assessment of fat-free mass. And so it's within that context where I'm fairly confident to propose that, as family physicians, we could use the BIA as our technique. The other thing that we wanted to assess was whether or not the cutoff points that we use for gait, for muscle strength, and for fat-free mass, if our numbers were relatively different compared to the published numbers by the European Working Group. And so what we did was that we did a series of studies on our elderly populations. We did a series of studies on our young individuals. We then determined, using the young individuals, to determine what our cutoff points were. And the truth be told was that what we got in terms of our numbers, again, were within the range of what it was that the working group had recommended for the different cutoff points for the assessment of sarcopenia. So what it basically tells us in a summary is that the established criteria are relatively robust in our scenario that we can actually use. So once it is that we have made the diagnosis of malnutrition in our elderly individuals, what do we do? So we have done the screening, we have said that they're probably malnourished, we have done the assessment using the techniques that we have, and we have said, yes, we have confirmed the malnutrition. Then really the next step is to develop a care plan. In developing this care plan, there are many considerations that has to be taken into context. So the dietary intakes, the usual dietary intakes, do they have food intolerance, allergies? Do they have specific food preferences? What are their cultures? What are their beliefs? What are the underlying diseases that we have to be thinking through? Do they have normal gut function? Can they chew? Do they have malnutrition? Do they have diarrhea? All of those sorts of things. Do they have an inflammatory disease? And of course, more importantly, we have to think about what are the social support and the settings under which this individual that we're seeing is. Are they in a nursing home? Are they at home? What's the caregiver? What's the educational attainment of the caregiver? All of those sorts of things have to be taken into consideration. So what it basically means is that your nutritional care plan really revolves around engagement of a multidisciplinary team, of which the nutritionist and dietitian are key players in this particular activity. When we think about specifically about what does the nutritional intervention look like, it's really basically two main types. We can do some form of supplementation, or we can offer what we call specialized nutritional support. In this particular talk, I will not discuss specialized nutritional support. That requires another half a day. But certainly when we talk about supplementation, some of the things that comes to mind and things that we have to be able to do is meal planning. And I said, this is probably best done by consultations with your dietitians. There are other techniques that can be done, such as what we call food fortification. And as I mentioned, the oral nutritional supplements. The Ministry of Health does provide us with some resources that we can engage with our patients. And I've provided the website to some of the Ministry of Health resources that you can engage with, which really give us some broad guidance as to what we call healthy living. And essentially, what does this broad guidelines entails? Well, essentially, it's to try and eat a variety of food from all food groups. So our dietary recommendations is what we call food-based. Try and ensure that we increase the amount of fruits and vegetables that we consume on a daily basis and reduce the intakes of salt and sugar or drink. But more importantly, activity number 8, which is to try and ensure that physical activity is an essential and daily part of our routine. And this presents the same information in the previous slide using the red and green thematic approach, which is what we now do in the primary schools, which really says that the greens are the things that you should aim to do, and the things that are in red are the things that you should really avoid as much as possible. So some other interventions, as I mentioned, I did speak briefly about the diet intervention, but there are other lifestyle issues that we will need to discuss with the patients and their caregivers, the whole issues of exercise, alcohol and tobacco use, the whole concept or technique that we may use to try and effect change, which is what as primary care physician we call a motivational interviewing approach. We will involve other healthcare professionals, the specialists, to help us with some of the other underlying disease that they may have, or social worker or physiotherapist, and of course our dietitians. There may be drugs and specific drug interactions which may interact with our food, and of course there may be some procedures that are necessary. So the long and short is that the approach to the individual with nutritional problem is a multidisciplinary approach. Before I close, just to mention a brief thing about some of the oral nutritional supplements that exist. We recognize that we should try and aim for much higher protein intake, especially in our elderly individuals. Most of us will go somewhere about 1 to 1.5 grams per kilogram per day. But more importantly, in things about weight training is what needs to be done. At least 3 times a day, 30 minutes exercise in many of the larger muscle groups seems to be the key things. We do know that there's controversial impact of oral nutritional supplement on some specific outcomes. What we do know is that it improves energy and protein intake, and in some studies it has shown increase in mobility. When it looks at some of the hard endpoints, such as the daily activity, task of living, mortality, and quality of life, there are some variable effects. We know one of the things that individuals, as they get older and they become bedridden, they may get bed sores, or they may get ulcers that take long to heal. We know that oral nutritional supplements, especially those enriched with what they call immune components, such as arginine and glutamine, may have some improvement in their healing rates. So in summary, poor nutrition is a significant public health problem in Jamaica, affecting about 60% of individuals in adulthood. We know that sarcopenia and frailty increases the risk of morbidity and mortality. We can identify these individuals using simple tools that have been validated, and we, in the process of TMRE, have validated a few of them, such as the mini nutritional tool or the SARC-CF tools. And any intervention that we think about requires multidisciplinary approach. Some of the nutritional interventions would include dietary advice, meal planning, and of course, the addition of oral nutritional supplement. But more importantly, one of the things that we must emphasize in our older folks is physical activities, at least 3 times a day, and a focus on weight training is something that we need to do. So with that, I thank you, and I'll take this. No, I'm just on about time. So if there are any questions, you can just put them in the chat, because I have some emergencies at home that I might have to deal with, so I'm not guaranteed that I'm going to be here for all of the program. So thank you again.
Thank you so much, Professor Reed. As usual, a very engaging presentation, and really showing us things that are applicable to us as family doctors, screening for malnutrition and sarcopenia, being part of the team that deals with nutritional intervention. So we do thank you very much for that. And I would ask persons to put any questions they have for Professor Reed into the Q&A tab, so that he can address them in writing in case he's not able to stay with us for the question and answer session later on. So Professor Reed, thank you very much for that. We're going to move right on to our second presentation, because I don't think we have a sponsor presentation at this time. So we'll move on to our second presentation. And I want to introduce to you Professor Karen Carpenter, who is the head of the Institute for Gender and Development Studies Mona Unit at the University of the West Indies. She is a licensed counseling psychologist in Jamaica and a Florida board certified clinical sexologist. She also serves as director of the Caribbean Sexuality Research Group Clinic at the University Hospital of the West Indies. A published author, Professor Carpenter's works include Love and Sex, The Basics, Questioning Caribbean Jewish Identity, Interweaving Tapestries of Sexuality and Culture, and Language, Race, and the Global Jamaican. She also hosts a popular online program, Love and Sex, on Facebook. It is our pleasure to welcome Professor Carpenter today to speak on sexual health and aging, myths versus truth, and relationship dynamics. Professor Carpenter, over to you. We are seeing your screen. We are not seeing you or hearing you yet.
Okay, well, you should be seeing me.
Yes,
Is on, and you should be hearing me now.
absolutely.
I
Thank
had
you very much.
unmuted. My apologies.
Go
So
ahead.
saying I'm going to mute my video because it's less distracting. I was saying thank you for having me and a good Sunday morning to everyone. I'm going to jump in by starting with looking at an overview of what we're going to look at today, and then we move into the rest of the slides. And I don't read from slides, so I'll expand on each of the bullet points that we see. We want to look a little bit at the sexual response cycle because that's our basic framework for looking at sexual dysfunction and looking at how sexuality plays out in different age groups. I had to look up the definition of aging this morning just to remind myself where we start aging. And so we're looking at our baby boomers and above when we talk about the aging population. So we have to remember the time at which people are born. We have to remember the age in which they're born and what the sexual messages are or were that they were receiving at the time that they came of age. Beyond the sexual response cycle, we look a bit at aging and sexual functioning in both women and men. We look at female and male sexual dysfunctions and dysfunctions in both sexes. And then we want to wrap up with a psychosexual approach. What would therapy do in these contexts? So the sexual response cycle, and we say Colgate is good, Colgate is good, Colgate is good. No matter how many times we speak about it, we have to again reintroduce it. If you think of a watch or a clock, the sexual response cycle starts here and goes around the clock. So we begin at 9 o'clock with desire. Most people are unaware that desire takes place in the mind. Most people believe that when they feel aroused is when their desire began, but that's not actually true. Desire begins in the mind with us wanting sexual activity, seeing something that ignites our sexual thoughts, having thoughts about a previous sexual experience or any other memory or visible, present stimulation. And that stimuli is received in the brain. And the brain says, let's get ready for sex. So we move from the mind connection, which most people miss, to the arousal when the body begins to respond to the brains. I think of the brain as a CPU, a central processing unit. So it's going to tell the rest of the body what to do. And so our arousal then begins. And our arousal means that blood is directed towards the genitals, blood is directed towards the skin. We feel tingly sometimes. You're very sensitive to touch at that time. Both the male and female organs become engorged. The female organ, labia majora minora, inflating to accommodate the thrusting. So it acts as a cushion to the pelvic girdle, and the male sexual organ engorging to create an erection. And that arousal is going to be facilitated as well by the thoughts that we're having about our partner, our experience, our context, etc. So the mind is also aroused. If we have enough stimulation, we usually achieve an orgasm, and an orgasm occurs in the brain, in the body, and in the psychology of the person, the psyche or emotions. So the brain recognizes that it's about to experience a release. It directs the body to, in the case of men, to ejaculate, and the ejaculation and orgasm are very closely timed together so that men think that when they ejaculate, they have an orgasm. They're actually not the same thing. You can also have a dry orgasm. You can have an orgasm that isn't accompanied by an ejaculate. Women also experience the tension and release, what we call the orgasmic response, the orgasmic flush in the body, almost like a sort of Robin Redbreast I was trying to explain to someone this week. So the flush is between the breasts, and on women who are light-skinned, paler women, you will see that flush very easily. Most persons, almost all persons, experience a tension and release during orgasm. And then there's, of course, what the brain does with its chemical lab. It releases drugs within the brain that help us to feel elated, help time to slow down, and help us to bond. And we look at those. So our emotions are affected by those chemical responses. After the orgasm, we have resolution or rest, and this is called a refractory period. During the refractory period, men and women experience different time lags. Men tend to take longer for the refractory period to pass. Women tend to take a shorter time. In younger women especially, and younger men, the comparison is somewhere between 5 to 10 minutes for women and 20 minutes to half an hour for young men. So, and we're talking about young there being 20s, 30s, right? And as we age, we might find that the refractory period expands. It's more. So we want to keep this in mind as our template as we go through the rest of the slides. On the bodies, I've highlighted the erogenous zones for men and women and areas where we tend to receive stimulation if touched. And of course, not everybody's response is the same. So more. The body and the brain collaborate. In fact, they conspire against us to bring us back to that orgasmic experience. The endorphins that are released, they help us to relieve stress. They help us to relieve pain. And I often say to folks, if you think of endorphins, think of chocolates. It's a feel-good drug. It makes you feel a sense of well-being and euphoria. And they're released during pleasure activities such as sex, exercise, massage, eating. Dopamine. I like the name of this drug because it makes us feel dopey. We get the sense of prolonged and intense reward periods. So that's the body saying to you, oh, wow, this sexual activity, this orgasm is lasting a half an hour, 2 hours. People report all sorts of protracted periods of having sexual activity. But actually, the sex act takes between 7 to 15 minutes on average. It feels like 45 minutes and a half an hour, but that's hardly likely. And if it is, it's usually enhanced by something else or a stop-start method. So sex, shopping, smelling cookies, baking bread in the oven, all of these can trigger a dopamine release or a rush. Oxytocin, which is released last, is a drug that helps us to bond. I often caution folks that you fall in love with an orgasm, not the person, but since it's operant conditioning, the person is there when you're having the orgasm, and therefore the person acts as a proxy for bringing you back to the orgasm. And that's nature's way of getting us to come back for more of the sex. And that's naturally to keep us on the planet. Without sex or some kind of reproductive activity, we don't stay on the planet. So it's a clever way of nature getting us to come back and have another sexual experience and another sexual experience until we can, in fact, reproduce. It's interesting to note that research shows that for every 1,000 that take place on the planet, only 1 results in a pregnancy. So primarily, human beings, as they say, are the sexiest animals on the planet with the largest organs generally, and also engage in sex far more than other mammals, and sex that is not reproductive. So the notion that we only have sex for reproduction is a fallacy. We eat to keep alive. We just had a talk on nutrition. Yes, we eat to keep alive, but certainly the pleasure of eating brings us back to eating again. Well, sex is very similar to that. Aging and sexual functioning in women and men and women. They're physical things, of course. Anybody who's a baby boomer is beginning to experience some of these physical things that might interrupt sexual activity. And these might include decreased mobility, less sensation in the genital area, less circulation in the genital area, and certainly if you're experiencing any pain. Psychological attributes that might prevent us from engaging sexually include a sense of rejection. Sometimes a partner feels rejected, a partner feels inadequate, they may feel unattractive, they may feel emotionally alienated from their other partner. And this can be through any of the many things that we encounter in life throughout a partnership, especially long-term partnerships with the same person. Relationships go through stages and they go through ups and downs, and these can affect certainly the desire for sexual activity, even if the functioning is still in place. The other one that I often bring up is desire discrepancy disorder, which I will touch on in a minute. So the diagnostic criteria for sexual dysfunction includes several symptoms: reduced sexual thoughts, fantasies, decreased initiation of sexual activity, and decreased sexual pleasure. If one partner was a person who initiated generally, and the other partner was a passive but receptive partner, then when the partner who normally initiates stop initiating for whatever reason, it becomes difficult for the passive partner to take on the role of initiator. And often there's role confusion at that point in time, and people feel rejected. And if you feel rejected, then you're certainly not going to reach out. But I want us to be careful to note that all the diagnoses within the DSM require that there is a presence of distress. If partners are happy with the level of functioning or non-functioning sexually within the relationship, we do not consider this a dysfunction. So we have to be cautious not to simply look at numbers. Everybody wants to know, what's the normal amount of sex, doc? How much sex should we be having? We do have averages, but that doesn't mean that every couple will experience the same levels of desire or activity, or indeed penetrative activity. Because in Jamaica, we tend to think of sex as only penetration, but sex is intercourse, outercourse, and all the courses. So when we think about the low libido, high libido, it's relative to your partner, and it's relative to what we consider to be average functioning. Most healthy couples who are well disposed to each other and not experiencing problems or acute stressors are having sex 2 to 3 times a week. Naturally, as people might age or there are other things in their lives that become paramount, like the raising of children, that sandwich generation that's taking care of children and parents as well, and that can be for a very prolonged period, that's going to put a stress on the individuals in the relationship, and it may affect their sexual desire. For some people, sex is a release that they need when they're facing stressors. So people are different in that regard, but it must be causing distress for one or both partners in the relationship for it to be considered dysfunctional. So female sexuality and aging. Some of the dysfunctions that we encounter for women, and I will make a little addenda to this, is orgasmic disorder, sexual interest and arousal disorder, or dyspareunia, pain on penetration, or sometimes even on arousal. I've known women who become aroused and feel pain, especially when they have had endometriosis that's now taken care of. They may have some memory sites and a reaction as well to the act of penetration that causes them to tighten, causes them to be tense, and creates pain sites. And then we have that catch-all, other specified sexual dysfunction. There used to be very, 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 very long ago, I can't remember how many iterations of the DSM. We're now at DSM-5 TR, but perhaps in the early DSM days, I don't know how long it's been out of there, the notion of frigidity in women. This is a term that's not used and hasn't been used certainly since I've been practicing for almost 25 years now. I certainly wasn't trained with that term, so that predates me. And I think with Masters and Johnson, that term may have gone out of use. So the notion that a woman would be frigid because she didn't want sex, meaning frozen, unreceptive, incapable of having sex. And so a lot of sexual dysfunction attention has been placed on women, and a lot of sexual function attention has been placed on men. It's often the question is, well, what is a woman doing? And so we've not recognized men's aging sexually quite as much as we have with women. And perhaps because women have a visible cessation of their periods and menopause, and that has become a very popular topic today. I'd love to see as much attention placed on andropause, because most men are engaging with women, most women are engaging with men, and even if you're not engaging with an opposite sex partner, you need to know what's happening in your partner's body, right? So other specified sexual dysfunction also include dysfunction caused by medication. Some medication can interfere with desire. Some medication can interfere with lubrication, the ability to gain and maintain an erection. So those all fall in that catch-all phrase now. And we've taken out the notion of women not being able to be sexually interested at all. Male sexuality and aging, hypoactive sexual disorder, low sexual disorder. This would be, I suppose, the equivalent of frigidity in men. So a lack of interest in sexual desire. And let's not forget that there are illnesses that affect and impede sexual functioning in men and women and circulation. And of course, diabetic patients will experience certain types of dysfunction, and also patients with heart trouble, heart disease, may experience other types of dysfunction, and some medication for hypertension can lower your sexual desire. Also, some of the heart medication lowers sexual desire. So often we want to know, is there a pre-existing condition? Is there a comorbid condition? How is the person being treated for this condition? And how can we work in an integrative practice with the GP, the general practitioner, the OBGYN, or the urologist to bring about the best outcome for the client? And of course, within therapy, we refer to persons as clients, not patients. Erectile disorder, very, very common among men, young, middle age, old, it doesn't matter the age. We see quite a lot of young men with erectile disorder. So much of erectile dysfunction is caused by psychological factors, not necessarily physical factors or disease, but we do have a disease orientation to these things. So we have to kind of look under the surface at what else is happening in a person's life. Premature ejaculation and delayed ejaculation, and I've more recently encountered also unexpected ejaculation. And I've seen this in people on heart medication where they did not expect an ejaculation at that time, but it was neither falling within the range of premature, which is 1.5 minutes, early ejaculation prior to the partner wanting to experience an ejaculation. So we distinguish between early ejaculation and premature ejaculation. And often early is going to fall within sort of 2 minutes to 3 minutes. And we usually want to know how long did you thrust before the ejaculation. And sometimes it can be anxiety, it can be overstimulation, it can be a desire to please, as well as we're going to look at how long has the dysfunction been present. So again, we have other specified sexual dysfunction for men as well. And that's that wide category that I just spoke about, which includes medication interfering with the ability to gain and maintain an erection, the ability to have an ejaculation. Many young men in Jamaica actually practice delayed ejaculation. Yes, and I think the term they use is tampon it long. So they've got this notion that if they can delay ejaculation for a very long time, then it means that they're a better lover. But we see in partnered relationships, of long-term relationships, where this can also have a negative effect on the female partner who believes that she's not desirable enough for the man to have reached that crescendo that gives him an orgasm and therefore an ejaculation. So it can have its negative impacts as well. Stopping an ejaculation for long periods of time is not necessarily to the benefit of the partnership. The biological causes, which as general practitioners, you will all know, and these of course relate to hormone levels. And nature is a little unkind in this regard, because if men and women are aging together within a sort of, 2 to 5 year period of each other, or 2 to 7 year period of each other, then we're going to see that for the man, the testosterone levels drop dramatically after they get to sort of 30, 40. Yes. And by the time they've got to 60 or so, 70, 80, then they've dropped dramatically down to the ankles. So men's testosterone levels plummet after 30, 40, and women's estrogen levels reduce to accommodate the menopause. But the irony of this is that with menopause, women gain a tremendous benefit, which is that they no longer get pregnant. So for the first time, a woman can have sex the way a man has sex, to the extent that she no longer worries about pregnancy. She can focus on the pleasure aspect of sex. Many women do not experience all of the ravages of menopause. Very few women experience everything. And I find often we have some pre-existing conditions such as anxiety disorders or personality disorders, mood and mind disorders that are conflated with the symptoms of menopause, and they roll into a ball, and people say, oh yes, it's a menopause, why you're irritable, erratic, you have poor emotional regulation, don't want to have sex, etc. It's not always the case. If we do a good history, sexual history, we often find that there are some things that existed before, and we have to deal with those before we can talk about how menopause has affected sexual drive. But as I said, ironically, women ought to be experiencing greater sexual interest when they're no longer able to get pregnant, and men are having less sexual functioning. So this is quite cruel in the sense that if you're aging together, a woman who can have passive intercourse is going to be able to have more sex than a man who has to have an erection in order to penetrate. But there are many other things that couples can be encouraged to do to arrive at pleasure. So dysfunctions in both sexes, well, pregnancy affects both of them, even if it's only the woman that's pregnant. And sometimes pregnancy, which is often looked at as a blessing, of course, we don't look at the ravages of pregnancy on the female body. We don't look at how pregnancy affects your ability to digest food, your ability to, as most women know, to go to the bathroom regularly, that bladder problem that arises in pregnancy and sometimes doesn't go away. And of course, menopause also brings with it its own challenges. Some women experience dryness, not all. Some women have their tissue degenerating and it becomes very delicate. They experience pain on intercourse and get what we call little paper cuts, what I call a paper cut. That's how I describe it to women. So intercourse can actually cause them some damage. So it isn't in all women, certainly, but the pregnancy and menopause certainly interfere with women's desire and women's ability to be available to their partners. Peyronie's disease that I don't hear a lot about, and I want to hear more urologists speaking about. We have quite a population of men in Jamaica who felt that when they went into the sex act, particularly penetrative sex, they were on the battlefield. And so this rough sex, this hard sex that's popularized in dance hall, etc. Later on in life, they start to develop that scar tissue on the inside of the penis, and they develop a bend in the penis. And I hear more and more men coming to me with that challenge now and wanting to know how to get over that problem. Regrettably, they come when it's been there quite a long time. In sex therapy, some of the things that we want to ask when we ask about any of these dysfunctions or how people are functioning due to aging, is it generalized? In other words, have you always had this problem? Is it situational? Has something changed in your life? Loss of job, loss of a family member, loss of home, any of the things on the Holmes-Ray distress scale that we know affect human beings? And is it partner specific? Does it only occur with a particular partner and not with other partners? Never occurred with another partner? And certainly where people have multiple partnerships, we're able to ask this question because you can tell that some people are going outside the committed relationship in order to function differently. And then they see that the problem crops up again. So that we know then that it's not partner specific. Relational response to sexual dysfunction, aging, and sexual distress, lack of and loss of desire, can often be a sense of confusion and rejection because people are not so tied into each other's time clocks that they're both experiencing it at the same time. One partner may still be able to experience arousal, great desire, find their partner very attractive, but the other partner is not as receptive. And this causes the partner to feel rejection. Suspicion of affairs. Many partners, when they see a lack of libido in their other partner, they suspect that the partner is getting the sex somewhere else. I've found that particularly for women being suspicious of men, that a number of the men report not being able to function in the same way. And this is men approaching 50, men in their 40s who are saying to me, I just don't have that drive. I have other concerns on my mind. And again, that's a sandwich generation. So they may be taking care of parents as well as children. Lots of stressors. Feeling of being undesirable, loneliness and depression, the repression of your libido or the lowering of your libido. And I also see where there are cases where a partner who started off as a high libido partner drops down to a low libido partner because they're tired of the rejection and therefore are no longer interested in sex within the relationship. So people don't operate on a time clock that says, because we've lived together for this length of time, we're both going to experience the same thing at the same time. Of course, it's deeply frustrating and sex becomes a duty rather than pleasurable. What's the psychosexual approach? And here we're coming to the end of the presentation. How do we approach these things in therapy? We look at sexual dysfunctions as a we problem in a couple, not a me problem. And I think that me orientation suggests that, oh, you go and fix yourself and come back. Well, that's not how it works. And while we might work for some time with the individual, we encourage that the individual invite their partner into at least a few of the sessions, even if they don't want to do all of the therapy together, so that you can both understand how better to please each other, how you can overcome the challenges that come with aging. And aging doesn't present so much of an obstacle as an opportunity for diverse ways of approaching your sexuality. What's missing in the Jamaican population, certainly, sexual education about male and female sexual functioning over the lifespan is very, very badly missing. Women are singled out as problematic in sexual relationships, and psychosexual education at all levels of the society is very poor. We have a disease orientation that says that if something is wrong, then you're problematic, you must be treated with medication. That is not always the case, and pleasure seen as deviant makes people feel embarrassed and ashamed when they have a sexual dysfunction, because why would a big person like me come and talk to you about my sex life? I should know about this already. But that is actually a wrong-headed notion. At a clinic at a hospital, our oldest client was 84. And himself and his wife came in, and his wife said to me, Doc, you know, him is a funny little man. Because she couldn't understand how suddenly at 84 he wanted to resume sexual activity. But fabulous couple. We enjoyed working with them, and the staff was just absolutely over the moon about the fact that they were still seeking to be together in a sexual relationship. So we need to have a look at our ideas about sex, sex as pleasure versus a performance, sex as pleasure versus reproduction. These are things that we need to challenge. We have to have the difficult conversations, and that can be very time consuming. We have to set the boundaries for confidentiality. What we say here stays here. So I say to couples, don't discuss your problems with friends. Your friends are not likely to have enough information to be able to assist you. And when you're having a good time, you don't tell them that you're having a good time. Discuss it with a professional. Come to your GP, come to a doctor, find someone who can assist you. Get a person-centered experience. Take your sexual history with a professional who can assist you in overcoming the challenges, and look at the frequency, the menu, what do people want in the bedroom, and what does sex mean for them? And so those are some of the things that we're going to ask. What's your sexual history? How often do you want sex? What do you want on the menu? What does sex mean for you? And who gets what? Do we both have to want the same things to have a pleasurable experience? Communicate your needs, your wants and your likes, but please communicate it outside the bedroom. I think it's awful when couples start dissecting the sex in the middle of a sex act. That's not the time to discuss it. Wait until you can have a civilized conversation over breakfast, over coffee. Say how you feel rather than pointing the finger at your partner. When you do X, Y, or Z, I feel loved, desired, wanted, etc. And get the help again of the therapeutic intervention to be able to communicate better. Think about the things that bring you both pleasure. They're going to be different. What communicates love and understanding to your partner? Because that whole psychological readiness for sex and sexual activity has to be in place. It must be a welcoming environment for people to function satisfactorily. So Again, these are not things that you learn overnight. I thank you for your attention and thanks for the invitation.
Thank you very much, Professor Carpenter, for that interesting and enlightening talk, looking at sexual dysfunction, bringing out the fact that to make a diagnosis of sexual dysfunction, there must be the presence of distress, and also emphasizing that it is not a me problem, but a we problem, and that when we are dealing with sexual dysfunction, we do need to look at both partners and work with them. Thank you very much for those timely reminders. And I would ask the members of the audience who have questions for Professor Carpenter to put those in the Q&A tab so that we can deal with them in a little while when we have the question and answer session. Our third and final presentation for this morning is going to be one to do with cardiovascular aging. Dr. Victor Elliott has actually done a recording because he's not able to be with us today. And we are going to look at that recording, but we also have with us Dr. Mike Posang, another cardiologist who will be able to answer any questions in real time. So I'm going to tell you a little bit about both of them at this time. Dr. Victor Elliott is a consultant cardiologist and interventional cardiologist at the Cardiology Unit, University Hospital of the West Indies, and is also the CEO at Partners Health, Heart and Health. He completed his cardiology and interventional fellowships at the University of Toronto in Canada. He is Canadian board certified in cardiology and interventional cardiology and has published and presented his research work at several cardiovascular scientific meetings. In addition to this, Dr. Elliott is a member of several professional organizations, including the American Heart Association and the Association of Consultant Physicians of Jamaica and the Caribbean Cardiac Society. So in a little while, we are going to hear his presentation. And when it comes to question and answers, Dr. Mark Posang is going to be here to give us his expertise. Dr. Posang is also a cardiologist who is attached to the University of the West Indies. He also studied in Canada, and he has both a private practice, both in Kingston and Portmore, as well as a practice at the University Hospital of the West Indies. And we are very glad that he was able to take the time to be with us to deal with any questions that may arise. So I'm going to ask Mr. Heron Sam to go ahead and let us see Dr. Elliott's presentation.
Good morning, everyone. First, let me thank the Association of Family Doctors for inviting me to do this talk on cardiovascular aging, navigating hypertension, heart disease, and frailty in older adults. I'm sorry that I cannot be there in person, and I hope that this presentation will live up to your expectations. It's a unique topic, and I'm very glad to do it. I am Dr. Victor Elliott, cardiologist from Partners Heart and Health and also at University Hospital. And let us celebrate a good World Family Doctors Day. So first, let us define what is frailty. So it refers to a relative stable state of vulnerability for adverse health outcomes due to social and living conditions. So it involves the vulnerability of your patients to basically poor outcome and the different factors that affect that. It is a process of declining physiological and physical conditions. You can also add mental and psychological conditions to this. So you're looking at the factors that affect your patient's developmental vulnerability, and if vulnerable, as to how that is managed, especially in the highlights of different conditions, morbidities, that may lead to mortality. There is a frailty scale from 1 to 9, and hopefully most of us, if not all of us, are in at least 1, 2, or 3, which are relatively well with different levels of fitness and are able to manage ourselves daily without any real inhibition. At 4, you notice it's when no vulnerability steps in. So you're not yet dependent, but your conditions limit your ability to function daily, and hence you're more vulnerable to come in a state in which you're going to become reliant. And as reliance now comes in, you go from mild, moderate to severe frail, in which you're now completely dependent on other people for your personal care. And then you have very severe, in which these persons, yes, they're on their last lap, coming around the last corner, not yet dying, but of course, any small illness, even a flu, the smallest pebble can push them basically over the edge. And notice 9 is terminally ill. You're approaching the end of life. You're not expected to outlive the next 6 months, but it is not necessarily dependent on levels 1 to 8. So you could be a 3 with a terminal illness. You'll be classified as a 9. And also with this comes in the whole aspect of dementia. Whether you have 0, mild, moderate, or severe dementia will also affect your grading in this. So a lot of what we're going to be talking about is going to be focusing on managing the patients who are especially at 5, 6, and 7, and a bit on how to get those patients in 1, 2, and 3 and stop them from progressing from a medical point of view, although as you see, there can be other social, psychological, and environmental factors. So believe it or not, we're talking about us. Because in the next 25 years, the number of adults expected to be in the age 60 to 79 is expected to reach 1.6 billion. And those are over the age of 80 expected to reach 430 million. Because we are living longer. We are doing something right despite all the criticisms about food, environment, etc. We are getting people to live longer. What we want is for them to live longer with minimal frailty, basically in good health. When people say to me, hey, you're going to live long, I stop them and say, live long and in good health. Don't just stop at living long. And we know as they get older, their risk of cardiovascular events, cardiovascular disease increases with each decade, and each rise in blood pressure. So 20 millimeters increase in mercury increases their risk. So we have to aim in treating hypertension and also other cardiovascular risk factors. And the focus on hypertension exists because hypertension is not only because of how many persons have it, but we know hypertension is the cause of a lot of other problems. To take, for example, a person can develop hypertension, have a stroke from the hypertension, decreased mobility. 10 years later, that decreased mobility causes them to fall, fracture their hip, being in bed, develop a DVT, which causes a PE, and they die from the PE. And we put the cause of death as a PE, when the reality is the person who started all of this was hypertension. So hypertension in the elderly is mainly a systolic hypertension that we're dealing with. And because women tend to live longer than men, you're also talking about a predominantly female condition. Now, because you're elderly doesn't mean the goals for managing high blood pressure changes. It's the same goals, and we're going to talk a bit about that. But there are challenges in terms of resistant hypertension, challenges in terms of hypotensive symptoms, and of course, the challenges that frailty brings along with it. So your elderly hypertensive tends to develop what we call arterial stiffness. This arterial stiffness is what pushes the systolic hypertension. That hypertension increases their cardiovascular mortality, and as we know, hypertension plays a role in the development of cerebral vascular dementia and cognitive impairment, which leads to further loss of independence, home institutional care, aka increased frailty. And this is even further complicated by if they have other comorbidities, and the use of a polypharmacy in this situation can become a problem. Arterial stiffness is something that develops with age. For most patients up to the age of 50 to 60, if they develop high blood pressure, they develop a rise in both systolic and diastolic, or predominantly diastolic hypertension. But as you go over the age of 60, what you find is that vascular remodeling sets in which you have increased hypertrophy, calcification of the vessels, and the development of atherosclerotic lesions. And some of you have seen this. You have seen those chest x-rays in which you can outline the aorta, the porcelain aorta. You can even see that sometimes in the coronary artery diseases. And this also affects endometrial function, and so the vessels become lose the ability to dilate. And then you have the breakdown in the matrix, the breakdown in elastin, so that pulse that comes from the heart every time the heart contracts, that flow through the vessels, and the vessel is supposed to dilate to accommodate that pressure, is unable to dilate, and so that pressure, instead of being accommodated by the vessels, stays within the lumen of the vessels, increasing their blood pressure. And so all of this just comes together to cause the arterial.
Now we see to have a pause in the video.
Sorry about that. Let me check. It should be okay. Orthostatic hypotension.
If
It
your
moves on
elderly
here.
patient has
Let's get
preserved
back to the
function, that is a
orthostatic
frailty
hypotension.
1, 2, 3,
Yes.
you treat them and manage them as with the younger patients.
Apologies for that, guys. You know how it goes. Wonderful presentation so far. Luckily, we know where we are. Let's get right back
Yes, it's the orthostatic
into it.
hypertension.
Yes. Let me get it up. In the meantime, let me play one of the videos from our sponsors, Indus Life Sciences.
Aminopep Fort in geriatrics. Aging is associated with a progressive loss of muscle mass, which increases the risks of injury and disability. A 2018 Journal of Nutrients highlights that inadequate intake of dietary protein has been linked with poor muscle function and physical decline in older people. Essential amino acids, which cannot be synthesized by the body, have primary role in the regulation of muscle protein synthesis, can potentially mitigate the loss of muscle protein during aging process. To meet the increased demand and to promote nutritional status, Indus Life Sciences brings Aminopep Fort. Aminopep Fort contains all 10 essential amino acids enriched with multivitamin and zinc. During aging, supplementation with essential amino acids stimulates muscle protein synthesis in the elderly, increases lean body mass, improves the ability of walking, provides immunity against recurrent infections and builds up energy and vitality. All essential amino acids in AminoPep Forte are in free form, which does not need further digestion and hence can be directly absorbed. AminoPep Forte is also suitable in compromised digestive capacity. AminoPep Forte offers adequate nutrition through essential amino acids and is an essential part of healthy geriatric face. AminoPep in convalescence. Following illness, body proteins like enzymes and hormones are rapidly broken down and are insufficiently resynthesized due to lack of essential amino acids. During convalescence, there is rapid weight loss due to loss of body fat and skeletal muscle mass. This is frequently accompanied by short-term self-limiting disease process like injury, surgery, and infection. Hence, supplementation with essential amino acids promotes tissue regeneration and healing, shortens convalescence, strengthens immunity, and provides sense of well-being. AminoPep Forte supplementation strengthens body resistance and improves immunity. AminoPep Forte shortens recovery phase and hence back to work faster. In old age and convalescence, AminoPep Forte acts as an ideal nutritional supplement.
We thank you for that sponsor
No problem, Doc.
presentation,
So
and I hope
now
we're
we're gonna
getting back
go.
to
Yeah, we're gonna go to the presentation. Apparently, there's an
us.
error. There's an error in the presentation. Let me just see if I can
So if we need to
bring it
omit,
up in
if we
PowerPoint.
need to go to skip a part, then we go forward.
Sure, that's what we're gonna have to do. One moment.
So the AHA nicely summarizes it like this. If your elderly patient has preserved function, that is a frailty 1, 2, 3, you treat them and manage them as with the younger patient. Get them to that lower goal in terms of the blood pressure, even though you're monitoring for the orthostatic hypotension and side effects. And you may again want to start with one medication and slowly titrate up. If there's some loss of function, you have to assess how frail they are. If they have moderate alteration with good functional ability, then you treat them as with the preserved function. If there is significant altered functional status, then you may want to treat them as you would treat the severely frail patient who has a significant loss of function and autonomy. So you may have to decide whether you're going to even start treating the high blood pressure, start low dose, maybe tolerating the higher levels of 150, avoiding polypharmacy. And if you do go below the 130, looking out for that orthostatic hypotension, still remembering that getting them below 130 does reduce the risk of cardiovascular events like a stroke. And especially your more frail patient, you really want to avoid a stroke. So it is a balance between the drugs, the effects of it, and reducing cardiovascular effects, but it's one which we just have to take slowly, function. When we talk about resilience, what we're talking about with the heart is the ability of the heart to recover from an insult or any condition, whether it's a direct cardiac insult or from some other comorbidity. For example, just by having a pneumonia or a flu can affect the heart function. But you want the fact that the heart is strong enough for them to recover and to bounce back from that can become a significant factor for them. So in our coronary patients with a high surgical risk, Doing multivessel PCI is optional. We can do it in a lot of them, though some with difficulty, and therefore should be considered once their surgical risk factor is high, but it can be done. We just have to use advanced technology for these patients. So essentially it's going up through the femoral artery into the aorta, crushing the valve that is there and putting in a new bioprosthetic valve, and that's better tolerated. Safety is better, no surgical scar, no cutting of the sternum, shorter recovery time, and avoid things like ICU. And so your patient in 2 to 4 days, they're out, and especially the more functional ones, you find that they're back to their functionality or even better within 30 days. And so this is something which we are now doing in the cath lab, and we have done at Partners Interventional Center, and the outcome has been quite good. Atrial fibrillation, a quick word. We know that the older our patients get, is the higher the risk of developing atrial fibrillation. By the time you reach 80, 1 in 4, and statistics are now going up to 1 in 3 patients have atrial fib. Atrial fib is a cause of 20% of stroke, even a higher risk factor for heart failure, and plays a role in the development of dementia. My push for this is your elderly patients, if they have atrial fibrillation, refer them for assessment if cryoablation is a treatment for them to get them out of atrial fibrillation, and so reducing the risk of those issues, hence reducing the risk of them going on to a higher level of frailty. And it does improve their quality of life. For those with atrial fibrillation, which are permanent, cannot undergo ablation, have to be on anticoagulation, but bleeding is an issue. So you're keeping them on anticoagulants is a problem, but then taking them off is a risk factor for stroke. We can do what we call atrial appendage closure, which cuts off the atrial appendage, again percutaneously, get them off the anticoagulants and reduce their stroke risk. So they're bleeding, refer them. We can do this. We have done this on patients, and the outcome has been great. So to kind of summarize, as I said, a large part of this has to do with early intervention and prevention and intervening before our patients get worse. And a large part of this is diagnosing your patients on the cardiovascular renal metabolic syndrome stage, which is highlighted here 0 to 4, in which a lot of our elderly patients may already be at a stage 1 or 2, stage 1, or have excess adipose tissue or dysfunctional, or 2, have already high blood pressure, diabetes, metabolic syndrome. Once you're at each stage, your mortality risk increases. You want to prevent them from going to stage 3, where they have subclinical cardiovascular disease and heart failure. And part of the assessment of this is monitoring the GFRs. Most labs tell you if the GFR is above 60. What you want is to know whether it's 90, 80, 70. Remember, that's stage 1 and stage 2 renal failure. If the lab doesn't report it, calculate it, because it means your patient is developing renal impairment, and you want to intervene at that early level, not when it is less than 60. And definitely you want to avoid them from getting to stage 4, where they already now have manifestations of the disease. So we want to achieve for our elderly patients, our frail patients, some amount of cardiovascular resilience, intervening early, treating early. And the one that has been shown in studies, one of the main problems with this is physicians' inertia. You're not accepting the newer treatments, whether pharmacological or intervention. You're not referring the patients, and you're making decisions for the patients instead of letting the patients, referring them to get the information and make a decision. I'm not saying this per se for Jamaica, but the studies have shown this is a common factor worldwide. So as we're dealing with our elderly, we have to monitor their blood pressure, be careful, see how frail they are, and the more careful you have to be as you're treating, and realize the frail patient can still get treatment for a lot of their cardiovascular problems. There are options which are safer for them, but the better thing is to intervene early, diagnose, refer, and let them get treated. Thank you very much. I'm sorry I'm not going to be there to take questions in person, but I hope this presentation was helpful.
And we thank Dr. Elliott very much for sending that presentation. Certainly the clinical frailty scale is something that is useful to us as family doctors. And the slide that showed the adaptation of treatment of hypertension in patients with frailty is something that we need to be cognizant of. And the slide that we didn't see on orthostatic hypotension is very important, because we remember as persons get older, they are more at risk of the orthostatic hypotension, where the systolic blood pressure may fall by 20 millimeters of mercury, the diastolic of 10 millimeters of mercury within 3 minutes of standing from a sitting position. So we have to be very cognizant of the dangers of orthostatic hypotension. And he also made the point that we need to make sure that we overcome physician inertia, assess our patients, and refer them to the cardiologist as needed. I know that Dr. Hosang is standing by. So if you have any questions for the cardiology presentation, please do put them in the Q&A tab. We are coming to the questions very shortly, but we will have a sponsor's presentation before that from Phoenix Gastroenterology, and it is by Dr. Mike Mills, one of our consultant gastroenterologists, who will be doing this sponsor's presentation. Over to Dr. Mills.
Hi, I'm Dr. Mike Mills. Here at Phoenix Gastroenterology, we're dedicated to providing you with expert healthcare using cutting-edge technology and a patient-first approach. With advanced technology and compassionate care, we provide precise diagnosis and effective treatment. In addition to endoscopy, colonoscopy, reflux testing and manometry, we're excited to introduce our new FibroScan machine. This technology is available for the first time to assess patients who have fat in the liver. This test is quick, accurate, and gives us a good idea as to how to manage patients going forward. Our team is committed to maintaining timely communication and providing effective, specialized care to all our patients. In addition to our Phoenix location, we're pleased to announce the opening of our second facility on Mountain View Avenue, where our team of highly specialized gastroenterologists are now available for consultations and care. Your health is our priority. And remember, listen to your gut. Take control of your digestive health.
Thank you very much. We have a few minutes for questions, because we are due to finish this session at 11, and we have just a few minutes. I do see two questions for Professor Carpenter. Do you recommend testosterone injections to help male impotence? And if so, can it be combined with sildenafil? Prof. Carpenter, you want to say, would you like to say anything on that?
And would you repeat the question, please, so I get it clearly?
Do you recommend testosterone injections to help with male impotence? And can it be combined with sildenafil?
Okay, so questions like that are open questions, which are very difficult to answer, regardless of the field that you're asking it in, because clearly it has to be contingent upon what the client has said to you, what their history is, whether or not they're on medication as well, and their age. And the challenge with testosterone shots, which I often recommend in conjunction with the urologist. Again, I believe in integrated practice, which means that something like that would be monitored by the urologist, should be looking at the T levels, etc. And notice I said she because the urologist I work with most is a female urologist. And then we would want to know whether or not they're thinking of having children. Remember that T-shot is going to slow down the sperm. It's going to make them slow swimmers. So we have to know if we want to take them offline for reproduction or we bring them back online. And so all of that advice has to be given as well as their own sexual and medical history. But often we find that there's a psychological problem, even where there is a physical problem. So T-shots, not necessarily for erectile dysfunction, but there's certainly other reasons why, in conjunction with a urologist, we might recommend it.
Thanks. And this question also seems a bit of one for urologists. This doctor says that they have patients with benign prostatic hypertrophy who sometimes experience blood coming from the penis after ejaculation. I don't know if you have any
No, that's
thought on that.
outside of my training and
I think so.
expertise.
I think so.
Yes.
I don't know I don't think we have any urologists on board right now. So, but certainly that is something we can discuss with our urology colleagues as to how to counsel. The last question this would be for Dr. Hosang. Can you clarify what is meant by the goals remain the same regardless of the age of the patient? Do you mean the target blood pressure? Would we not accept a slightly higher blood pressure in exchange for a patient being more functional? Example, less likely to fall and fracture a hip. Dr. Hosang, you want to say a word on that?
Hi, morning, Eileen. Thank you for that. So yes, it was in regards to the target blood pressure, I believe Dr. Elliott was referring to.
Right.
So yes, most of the time the targets are less than 140/90. And for some patients, especially those with renal disease and proteinuria, as well as diabetic patients, less than 130/80 should be our target. But having said that, we do accept higher blood pressures for the older patients, but especially those who have a high frailty index, because of the risk of falls and hip fractures, as mentioned in the question. So I agree with Kanchana that we do allow for higher blood pressures in those patients, but we still do want them to go as low as they can go. So it has to be a very individualized decision, and based on the patient, because if you can get them to 130/80, then maybe that's where you should be going. But if you think that if they're at 140, or even if they reach 135 and they start to feel dizzy, then you might say, well, anything less than 140 is probably not best for this particular patient. So it has to be a very individualized decision. But as Dr. Elliott said, our goals are basically the same. And as Kanchana said, yes, we do accept a higher blood pressure. So I agree.
Thank you very much. And thank you so much for taking the time out to be with us today. So that does bring us to the end of session 1 for this morning. I thank you all. I thank all the presenters and sponsors for this session. And we have had an excellent start to our morning, and I'm sure it is going to continue in the same vein. I'm going to now hand over to my esteemed colleague, Professor Monica Asnani, to moderate session 2. Thank you all for your attention.
Good afternoon, colleagues. I am just asking for 1 second as I switch.
Yes, Prof. Asnani, we know it's afternoon where you are. We are still in the morning here. The technology is wonderful now that we can be elsewhere and still participate.
Absolutely. And I'm so happy that I could actually do it. Oops, things are a little bit off. I'll take
Yes, you
my
need to
camera.
just adjust your camera a little.
Yes, I do need to. I was connected, but I'll just reset it in a couple of minutes. But thank you so much, Aileen. It's good hearing all the talks this morning, from starting with Marvin and then Prof. Carpenter and my good friend Victor, and listening to Dr. Hosang. We had a wonderful morning. It's still morning. I'm in Canada, but it's still morning, and no, it's just turning afternoon in Canada. So that was how my good afternoon went. Happy World Family Doctors Day tomorrow, May 19th, as the world celebrates the work of family physicians. And I'll start very quickly, because thanks to Aileen for catching up with the time and all the presenters for catching up with the time. I just want to start by saying that I'm really, really grateful to Seni, our president, the college, for always thinking of me and engaging me with family doctor activities, even as I'm a little bit lateral, but they all know that my heart is in family medicine. I work with persons living with sickle cell disease, which I've done for the last 22 years. So happy World Family Doctors Day. And I must say, when I saw the program, it is absolutely timely, as the United Nations celebrates and has declared the decade 2021 to 2020, no, to 2030, 2021 to 2030 as a decade of healthy aging. And as I said in another one of my meetings on aging, I'm getting there. And so, you know, it's really good to hear what's ahead, but especially working with our elderly to not only enable them to live healthy and productive lives, but also to realize, I think all of us as families, as children, as communities, as physicians and healthcare providers, we need to understand that what a huge, rich resource they are of experience and skills and history that we, the younger generations, must continue to use, you know, to our benefit and to the benefit of society. So happy to be here. We will get right into session 2, which is very, very exciting, because it starts with one of my very, very favorite professors, Professor Denise Eldemeyer-Scherer. We cannot have any meeting on aging without having this particular expert who has decades of experience working with persons who are aging and how really to deal with them. Professor Denise Eldemeyer-Scherer, who is a professor of public health at aging. She is a medical doctor and is the island's resident aging expert, who has spent decades engaging, researching, listening. I know that as firsthand, Prof, working and developing policy on behalf of Jamaicans over 6 years cohort. She is currently executive director at the Mona Aging and Wellness Center. Prof has brought so much visibility to our small island of Jamaica through her, world-renowned work in public health, not just in aging, but public health as well. She's at the University of the West Indies at Mona as executive director. She does research in public health and geriatrics, and her current project is introducing geriatric care into primary health care. Prof, we look forward to listening to another angle of your work, which we don't always pay much attention to, which is violence, injury, and abuse among older people. Over to you, Prof.
Good morning, Monica, and thank you very much. Please remind me how much time I have so I can keep it also on time.
Boy, can I say that you have as much time as you want, but you have 11 a.m. to 11:30 a.m. And just to remind our participants that Q&As would be at the end of the talks. So you have all 30 minutes. Sam will tell me if I'm saying something wrong. Sam? But
we're trying to share.
Yes, okay, Prof.
But I
Yes,
noticed Sam's not answering.
He
Oh, no, I'm
did.
so sorry. I thought I was unmuted. I'm sorry. I was talking this whole time. Apologies. Yes, you have all the time you want. However, our agenda says only 27 minutes. And
When it comes to
we're now seeing your screen.
But when it comes to aging, telling me I have all the time I want is very dangerous, you know. But
Very,
you are
very
fortunate.
dangerous.
Today's May
Very, very
18th.
dangerous. Yes.
Yes, but today's May 18th, so I do have to go to Heroes Park. So you're fortunate.
Okay, perfect.
Um,
And I am seeing your screen. It's up now. We're
I'm
on your
up.
first page. Yep, clear.
Okay. Thank you very much, and thank you for the invitation to participate. I too have enjoyed the previous presentations, and I particularly like the last question in terms of the blood pressure. We could also add pulse rates to that as well. I have patients whose pulse rate drops to 40, 45 during the night on some of their medications. So it's an area for us to be concerned about. But let me not interfere with that, and let me move to the topic that I was asked to do. One I was very reluctant to do, as Seni will tell you. But, okay, Annie, where am I? Oh, the mouse. Oh, I'm waiting for help. Where I click, okay. So I'm going to look at aging in terms of the definitions, because it's important for us to recognize we're not only talking about illness. The population changes that are making this topic all the more important as we are practicing physicians. I will look at it. No, it's going too quick. Annie, I need to go back. I need to go back. No, you're going for, okay, go again. Go again. All right, and I'll look at abuse, violence, injury, and abuse. Abuse is particularly topical now because the Senate Parliamentary Committee is meeting, and abuse keeps coming up as the main concern. I'm going to touch on that, and I will talk about the implications for all of this to us as practicing. So aging is a very complex process. We tend to think of aging as a physical process, but it's actually a lot more than that. And more importantly, it's a lifelong process. And a lot of the earlier discussion takes this into consideration. And how do we get people to realize at 70 you're a product of the 70 years before? The other important thing is that while it's a result of cellular damage, everybody has ages and has this damage at a different rate. So there's no common thing for you to look out for. It is associated with a gradual decrease in capacity. For some people, that capacity manifests as frailty and therefore affects the activities of daily life. For other persons, it's simply a slowing down. You will notice that people don't recover from an infection as quickly as they did 20 years earlier. And again, you have to know your individual patients. You have to work with them and ask them how they're feeling. What aging does do is there is an increased risk of disease. And the increased risk of disease is because of the longer time with the risk factors. Aging per se does not cause disease. And increasingly since 2015, the WHO has got us functioning, and I think Monica made mention of this, on not using a disease approach, but using a loss of function approach. The disease may be causing it, but we also have to look at the loss of function. Do they need a walker, etc., while you manage the disease? And it's also associated with life's transitions. Persons manage and cope with their aging process dependent on how they have managed with other life transitions. And all of these components can play a role in diagnosing and managing illness. So we have found through our research at Mona Aging and Wellness Center, as well as the international research we have available, of the 6 key health concerns. It's interesting that cancer is first, but you can think about it and you realize why. For older people, cancer kills. Managing cancer, treating cancer is out of the financial reach of most older people, only 20% of which have a pension. Arthritis, chronic pain, cognitive decline. People do worry about dementia, mental health issues. I was to take out that, ignore it. Chronic disease and risk factor management. Risk factor management, because we love to give our patients lovely diets, nutrition, without taking into consideration some of their financial restrictions. So why are we concerned? We're concerned because we care about older people. And I think, as somebody, Monica again said, we're all getting there. I'm there. But it's also because Jamaica is in the final stage of the demographic transition. Been a lot of discussion recently about the fact that the birth rate has fallen below replacement. What is also important as we think about this is look at that 0 to 14. It's fallen from 45.2% to 23% with further projections for falls. And this raises the question of who is going to look after older people or anybody else, any other vulnerable group in society, disabled persons, children with problems. Look at how the number of potential caregivers is falling, and that's important. We also have to look at life expectancy, because not only do we have population aging, but we also have aging of people. So more older people who are going to live longer, and this is an important consideration. The fastest growing age group in Jamaica is the over 80. That's the age group that we also see frailty in, and we begin to see the impact more so than in the younger groups. 60 to 70 being young, old, 70 to 80 being middle old, and then the old. So what are the implications of an aging population for the practice of family medicine? The social component is very important. I mentioned the caregiving. You have somebody in your office who is going to need some support and going to need some help. But also, social stimulation is critical to cognitive functioning. And as one gets older, there are losses around them. There's a loss of the workplace, the loss of loved ones. And the issue, and of course, the violence plays a role here, because older people are afraid to go out as much, and we worry about their social stimulation. I have mentioned the economic cost of life, and then add into that multiple medications, tests. Dr. Elliott spoke about the heart issues. Look at the cost of those. Without a pension, how does one manage them? Without a family member who can? And families are also stressed financially now, and we have the sandwich generation. Many of you would have elder parents as well as still younger children, even those going to college, especially with having children later. There are the environmental issues. Walking, we say physical activity, but the roads are potholed. The parks are not within easy reach. And of course, there are the political issues over availability. We see people arguing about wait time and that sort of thing. So what then are implications for healthcare? What we see with the aging of our population is a decrease in mobility. And remember, I said that we need to focus on function now. So if you're having a decrease in mobility, if you're stumbling a little more, if balance, then that is for the family physician to identify and to put in place through balance exercises, strength training, and of course, recognition by the person, things to help them improve. We will see an increase in dependence, some physical, but also financial. We know we have documented the increase in falls and cognitive issues. Please notice I'm saying cognitive issues. I'm not saying dementia. Smaller families, as I said, therefore less available caregivers. And the issues around healthcare accessibility and healthcare financing. It's very easy for us to say that, okay, the public system is free, but the transportation to get there is not. Some persons traveling from Maryland to KPH, the taxi can be in the region of $5,000 to $7,000. So we have to, the healthcare accessibility, we have to think of as more than simply whether is there a doctor present, is there a service? And of course, only 16% of older people have health insurance. So the issues around healthcare financing, and this should affect you because you need to think carefully before writing investigations. It's very frustrating to a family when they cannot afford what you've written. And now the older people are not going to tell you that they can't afford it. They're simply going to take the paper. But you know your patients, so you know who can and who can't. So the health issues, as I've mentioned, the increased chronic disease, function is very related to increased to sensation, to our intrinsic factors, our hearing and our sight. Can you imagine trying to draw up insulin on that fine needle if you're having sight problems and can't afford your glasses? So we think of all of these things. The sight and hearing are also going to affect falls. If you can't see, if you don't hear stuff. Older persons also consume more health services. Primary health care is needed. And the one that's becoming more and more topical is around the long-term care. And you may wonder what this has to do with injury, but injury and other illnesses such as strokes can increase the need for long-term care as well as home care. So our challenge as we talk about this is healthy years versus years of illness, loss of function, and increased dependence, resulting in the need for caregiving. Let us now look at these things in light of violence, injury, and abuse. So the Ministry of Health and Wellness data set, they have a wonderful data set on injury and violence, let me tell you. Defines injury as harm, intentional or unintentional, that occurs when the human body is subjected to excessive levels of energy. That's their definition. They can be minor, including scrapes and bruises, to major, such as severe injury. Some of the falls can cause severe injury. You've noticed that I've not mentioned the motor vehicle accidents, and you'll soon see why. The likelihood of injury among the 60 and over increases with reducing physical strength and mental accuracy. So now you see why I took some time to go through when this happens, because in your family practice, you should be screening for these things during your routine visits. Any injury, when combined with a comorbidity, increases the risk of death. So the death rate from injury, now this is death rate, this is not necessarily the numbers, in the over 60 is second only to the young age group. And injury-related deaths, although low, you will see that they are low, they are increasing. I suspect, have no evidence for it, but it will be in our next study. Between the two major studies we did, 89 and 2011, the level of independence and function among older people increased. It went from 78% to 90%. And therefore, what we are seeing is more active older people. And as I said in one of the slides, as you get older and there's more frailty, so you see that it's among the 75 and over that the deaths from injury are more likely. So our over 60 account for 12.2% of unintentional injuries requiring medical attention. Low number, but still, as if the death rate is higher than other age groups, you want to take it into consideration. All of this information is Ministry of Health data. We see marked gender differences. Males account for 9.1% of all male injuries, 56% of them unintentional, compared to 25% in the age group 20 to 29. So the male older population are more likely to have unintentional falls and that sort of thing than out, like guns and that sort of thing. 625 of the injuries were at home. Again, the relevance to family practice because of the need to ask about the home. Among females, of the 985 injuries, 80% were unintentional compared to 28% in the lower age groups. So again, we see the gender difference, and it's not surprising. Men continue to go out of the home more after retirement than females. So this is not a surprising finding. Falls, the major cause of injury. There's a study by Dr. Jason Tappan that he presented last year at the Ministry of Health Research that pointed out that during COVID-19, when elective surgeries were canceled at university, orthopedic surgeries, predominantly hips, were the #1 surgery and the #1 cause for emergency surgery. And we have data done by Dr. James that falls have increased 10 times between 2006 and 20 compared to assaults. So again, the importance of the falls. From the injury surveillance data, we had 765 falls in females and 773 in females. That actually surprised me. I expected it to be more in females. And the implications of the falls are the physical injuries, the fractures, the head trauma. Head trauma is one that we don't take into consideration often enough. I've had several subdurals from very simple things like a fall or even dropping in a pothole, and the subdural has not presented immediately. Remember, the brain in older people is smaller. It can shift more than younger, and therefore you can have oozing and you get a chronic subdural down the road. So one has to be very careful with older people. Soft tissue injuries, all of which can lead to prolonged hospitalization or certainly staying in bed at home. The psychological effect of a fall is we can't be understated, because we find that older people are afraid of falling, so they stop moving around so that they don't fall, decreased confidence and prolonged rehab, all leading to the increased healthcare costs, the need for walking sticks, physio and caregivers, and the increased need for long-term care. So what are our risk factors for falls? We have to think of the intrinsic as well as the environmental factors. Sight, hearing, frailty, reduced mobility, lower extremity weakness, poor gait and balance, cognitive impairment, the chronic diseases, and medications. The hypotensive effect of some of our medications, the antihistamines, there are a lot of them that we need to take into consideration. And do not forget alcohol. A lot of our older people, or some of our older people, do enjoy a drink. The home factors are the obstruction in the walking areas, the furniture, the clutter, untidy rooms, loose rugs. I actually lost a patient. The caregiver was very careful with making sure to take up the rugs. The family put the rugs down every weekend because her foot wasn't to touch the cold floor. She had her fall over the weekend. She broke her hip and she never left hospital because of her chronic conditions that were the fall was superimposed upon. The poor lighting, the lack of bathroom safety, the slippery floor, and ill-fitting footwear. Then we have to think about busy streets, uneven walkways, that sort of thing. So you have the outside environment. Remember that vision has an effect. The aging of the visual system has an effect, and perception and judgment are impaired. So older people will walk across the road thinking the car is far away when the car is right there. So we scream at them and we blow the horn without realizing that they think the car is far, and it would be much better to just stop. So we have to remove, the falls prevention is key, and this again is part of your family medicine intervention. Removing the clutter, maintaining the bedside light within reach, hallway lights, handrails in the bathroom, ensuring the bed is stable. A lot of our beds move up and down, you know. Ensure the non-slip but comfortable footwear, regular foot care, including cutting of nails, ensuring that floors are dry, and improving mobility and balance, as well as medication management. It begins with an assessment, the falls history, the medications, measure your postural hypotential, and then you have a fall-focused exam to include chronic disease, assessing gait and balance, time get up and go, chair stand, and a functional assessment. What can they do? The lab tests, because you're looking for thyroid, you're looking for things that could contribute to balance and gait problems, their sugar, and an environmental assessment. In this day and age, the environmental assessment is not as hard as it used to be, because you can ask them to send you pictures of their room, because we don't have time for the home visits that we used to. So the topic of today is abuse. And the medical dictionary defines elder abuse as harmful acts towards the elderly, such as physical abuse, sexual abuse, emotional, psychological, financial, which is what we're seeing, and neglect. But we have no definitions. Unlike child abuse, which we dealt with in the 80s, where we went through a long process of coming up with regional definitions, we have not started this process. It is a reportable offense, and it is covered by the Offences Against the Person Act. However, although we get reports, when time comes to ask the old person to give the report and go to the police station, very few older people will report a relative. And most of this is in-house. It's intimate violence in terms of something they know it's a caregiver or whatnot. We have regional definitions in documents by civil society on protecting the rights of older persons, but we do not yet have a Jamaican document. The rights of people, yes, they date back to 1948, but there were no old people in 1948. Life expectancy was below 60. And therefore, there are rights around long-term care and abuse that we need to think about. And we have no reporting and documentation system locally. Now you know why I did not want to discuss abuse, because there's really not much, unfortunately, to discuss, except to say that it is very important that we recognize it and we join in the fight to fight not a good word when talking about abuse, in the efforts to bring this to the front burner. We've not had much process other than the criminal process. The national policy does have preventing abuse as a goal, but we have not taken it to the next step. And let us hope that the parliamentary inquiry now going on will in fact take it to the next step. So, how much time do I have? What are the implications for community-based practice for our family doctors? We have to assume aging is valuable, even if it's challenging, that it's good to get old, while acknowledging that older persons can experience significant losses, physical, cognitive, social, and economical. Some of these are inevitable and some are not. Our response needs to be not to deny the challenges, but to foster recovery and adaptation. And the public health response aims to strengthen older persons and their support system and their ability to navigate and adapt. So WHO, for the past 10 years, as part of the decade of healthy aging that Monica mentioned, is trying to get us all to shift towards this integrated care that is not disease-focused, but is focused on function, and to be person-centered rather than disease-centered. And it's part of the universal health coverage goals of this decade. So ICOPE recognizes that as we age, there are physiological changes which can occur and increase the risk of experiencing decline in physical and mental capacity. And having more than one condition increases that risk. And as family physicians, our goal is to assess these physical and mental capacities as we assess the disease process and try to treat it, to see what advice we can give in terms of persons recognizing. One of the biggest problems an older person has is to recognize that, okay, I have some physical limitations and a cane would help me. Glasses would help me. And talk to your patients to get them to do that. And to screen for the geriatric giants, no matter, at least once per year, no matter what your visit is for. So hearing loss, malnutrition, obese people here eat a lot of carbohydrate and have low protein, vision impairment. Let us not forget mental health, the sadness, the depressive symptoms of being alone, urinary incontinence and falls are geriatric giants. And this is the link to the healthy aging, where you look at the environment, functional ability, and the intrinsic capacity I spoke about, locomotion, mobility, hearing, sight. So intrinsic capacity, just to summarize it, I've been mentioning it, is the composite. If you don't see something, quite often you don't hear it. And therefore, we as physicians have to help our patients to see what they need to strengthen. Psychological well-being and vitality are very important. And intrinsic capacity is a crucial concept in healthy aging, which is defined as the composite of all of these things. So intervening is about seeking to delay deterioration, cataracts, glasses, but also for us as physicians to monitor changes. So in your dockets to note, okay, you watch the person walking in, they're fine today, but they're stumbling tomorrow. There seems to be balance. And to monitor these changes so that you know when to plan an intervention and building them, as I said, into their regular visit. The functional capacity refers to an individual's ability to perform tasks, bathing, cleaning your teeth, etc. Of course, you have to establish whether they do it. I suspect if you're like my family, there's no point in asking any of the males in my family whether they cook or they go shopping, because they've never done it. Similarly, for many of our older females, they've never balanced a checkbook because they have allowed the males to do that. So you have to establish whether, in fact, it's something they always did. So do you cook? No. You have to ask, have you ever cooked? So these are things that in your practice become everyday questions, and you can build them into your normal history. So it just becomes an everyday. Integrated care is needed because older people are faced with fragmented care. Many older people are going to 4 or 5 doctors. They're going to hospital when they're referred in. Hospital doesn't talk to primary care and these things. We don't routinely have interventions to optimize intrinsic capacity, and that we need. Many, as I mentioned earlier, are too far from where they live. And more ageism is prevalent in our society. You're old. Why are you complaining? Expect some pain. No, find out what's causing the pain. I had a lady come to me and she wanted a hip x-ray. She was not my patient. She says, I hear you'll talk to your old people. I said, yes. Write me up for an x-ray, please. I fell and I want to check. She actually did have a hairline fracture. And she knew it. But her GP had said she was old. What's a little discomfort? So we really need to be careful about ageism and to fight against it. So these are the principles which I have been talking about. This is summarizing, maximizing intrinsic capacity, person-centered. Think about your person. What are the goals? How often have you asked your older person, what's your goal? Some don't want to be able to go and work. Some just want to be able to walk around the house. What are the community level interventions? What is the support for self-care? Most of your obese patients cannot bend down and cut their nails or clean them or dry them. These are questions you need to be able to ask so that you can give them advice. And clearly, as more and more get to 80 and over, even 75 and over, the support of the caregiver. Caregivers often just want to know when to take action, but they need to be able to speak to their doctor to ask a question. They don't have to bring the older person in every time just to find out do I need to do anything? Is this something I should be worried about? And integrated care says that, so it has 5 steps. Screening, comprehensive falls for incontinence, for cognition, intervention, monitoring, and community public health action. And your care needs to be based on an assessment of individual needs. Go back to the first slide where I said everybody has a different aging process. Everybody has different needs, preferences, and goals, and have a plan for somebody, which is much more than managing their diabetes or their chronic disease, and of course, coordination of services. So this is the flow chart, and I thank you.
Thank you, Prof. Wow, I wasn't even ready for it to finish. I was still listening intently. Thank you for a wonderful.
I was trying to keep to the time.
Thank you. You said it. You can talk about aging as much as, and I'm just as guilty when it comes to sickle cell disease. I can spend 3 days talking about sickle cell, if not more, nonstop. But Prof, that was really, really a great talk that just encapsulated so much of we as GPs need to be keeping in our forefront of minds. I love when you said that don't think, it's a little pain, go ahead. I mean, trust me, those things are so annoying. If we're going to say, you can't do this, you're 78. We cannot determine what a 78-year-old can do. They're the only ones. And I have to keep reminding myself that even though I look after my elderly parents, they still are older than me, which means that they have a lot more experience than I've had in life, and they know their bodies better than I can know it. But thank you so very much. I know there are going to be a lot of comments. Our participants, audience, we can be putting our comments and questions in the Q&A area. I hope Prof can stay back you can't, Prof? You can't. So will you please put them in the Q&A? And maybe Sam, if you will allow, we can do maybe just 2 questions live from Prof. And I'm not sure, we can send them on to her if our audience has really critical questions. Yeah, Prof?
Yes, definitely I'll ask them. Unfortunately, I have a floral tribute to go to.
Yes.
It's May 18th. So that's the anniversary of my husband's birth. So I need to go to do that.
Warm congratulations, I know, and thank you for giving us your time, Prof, on such a special day. Thank you so much.
I want to say one thing, though, when you were saying about your elderly parents, it's very important, and this is true of your patients as well. Remember, you're a youngster. You might think you've had 30 or 40 years of practice, but you are a youngster to them. And if you are a child, then you are a child.
Yeah.
And therefore, we have to suggest rather than tell. If you want to be successful with older persons, use suggestion rather than Now I have a problem because there's a comment in the chat that is asking me to put up back the chart. The unfortunate thing is I did the stop sharing, so I can't access the chart anymore.
Yeah, yeah.
But we can send you the chart. The chart's very important.
Yeah, yeah.
And it is going into the ministry is working on the primary healthcare model for geriatric care, and the chart will be there. So I will share the chart.
Yeah, that's really great. So we keep on their website to get whatever other information. I'm surprised that there's no policies in place yet about elder abuse, because I think it only gets worse with time. Any burning questions that Prof can spend 2 more minutes with us answering, and then we'll send any other questions that you all think of onto her, and I'm sure she will answer and we'll get them back to you.
Not seeing any in the Q&A at the moment. Let me see what's happening in the chat.
Yeah. Yeah, I'm not seeing anything in the chat.
Just excellent presentations.
Yes. Yeah. Yeah. Just about the flow chart.
Prof, I think that's what happens when your presentation is so amazing and you are the expert. And the way that you have shared is so clear. So thank you very much.
Thank you so much, Prof. Good to see you.
Thank you. Good to see you. Where are you?
I am at the sickle cell unit. I need to come and see you.
No, because Aileen said you weren't here.
Yes, I am just visiting my family in Canada. I return back tomorrow.
Arna has just posted about caregiver violence. This is something that, well, maybe I need to ask what she meant. Are you talking about the caregiver being violent or the family being violent to the caregiver? I'm not sure. Can you clarify?
Both, Prof, because it happens both ways.
Well, I already said that with the abuse of older people, until we have a system which includes identification, if I asked, we have what, 180 people on board, everybody's going to have a different definition of neglect. So as we did with child abuse 40 years ago, we are going to have to, as a profession, come together and have a checklist for what constitutes. We're going to have to design a reporting system.
Prof, for example, what is the situation where you have your caregivers who attempt to regularize the life of the older person to this is bedtime, this is get up time, this is eat time, you have to go to the bathroom, you have to, this it's a form of abuse where there's no freedom, there's no free time, and it's all about the caregiver being able to cope.
But you see, something like that is not going to qualify for criminal proceedings, which is what abuse is. And a law about abuse is going to be about criminal proceedings. So what you are talking about is operating standards, SOPs, standard operating procedures. My answer to you is change the caregiver. Somebody has to be in charge of the caregiver in terms of a family member. And the family member equally has some rights. You're paying the bills. And that's why so many don't want to go to nursing homes, because nursing homes, by definition of having 20, 30 people, have to have some regimentation. They can't be having 30 different meal times, etc. So it's about choosing the right caregiver. And you may have to go through 2 or 3 before you get the right one. Many of the families that I am dealing with, the old helper has become the caregiver because they know the person, they know the dynamic person, and they are more tolerant of the increasing dependency and brought in a new helper.
Just like how we train nursery nannies from time to time, I know St. Margaret's Church used to do that. Perhaps we need to have an active course that allows, with certain minimum credentials, to train caregivers. This is both in being the physical stuff, but also the emotional part of it, and how to deal with their own stresses and not take it out on their clients.
Yep. Agreed.
So I know we do have that training happening at Mona Aging, don't we, Prof?
We do.
Yeah,
we do.
Yeah. And
we're now working with the CHAs as well. We only have the southern region left to do. So we do, and there's a geriatric nursing for practical nurses, and that's now being monitored by HEART. So there are standards.
Excellent, excellent. I must say that practical nurses, and I can speak from personal experience, have huge hearts in Jamaica. And if you can find the right people, they are extremely caring. They might not have a lot of medical knowledge, but they have just about enough. The family member will have to. But the geriatric nursing for practical nursing is really a great initiative, and community health aides getting a little more awareness. Thank you, Prof. Thank you so much for your time. Thanks, Dr. Brown Morgan, for bringing this to attention here. Prof, we'll see you again.
Yes.
That's another one of our sessions. Do take care. Thank you so much.
Thank you all very much. Sorry that I have to leave you.
Not at all. Thank you, ma'am. colleagues, we move on to a short, not a break, but we want to do sponsors presentations. I'm going to invite Mr. Dayanandan from Indus Pharma, followed directly by Mr. Paul Russell from Abbott Nutritionals to make their presentations, and we are grateful to them for sponsorship of this very important medical conference. Go ahead, please.
Welcome to the world of Indus, and we are happy to join hands with you to serve the humanity across the globe through innovative healthcare brands. In just 16 years, Indus has grown from 1 to 120 products in 12 therapy areas. Today, Indus has spread its wings globally and is now present in 30 countries with 150 professionals spread across geographies like Asia, Southeast Asia, Africa, Europe, Caribbean, and South America. Excellence is not an act, but a habit at Indus. Our world-class products, affordable pricing, excellent supply chain, strong field force, and good business practices have accredited Indus with many excellence awards, like Federation of Indian Export Organizations Export Excellence Award, Farm Excel Award, Brand of the Year Award in Ghana, and State Bank of India Financial Discipline Award. What's more, now Indus brings you a 5-minute miracle. In today's fast and modern lifestyle, the incidence of heartburn due to acid reflux and GERD is alarming due to stress and busy schedules, overeating, eating irregularly or too quickly, eating just before bedtime, fatty, spicy, and fried junk foods, caffeinated drinks, carbonated soft drinks, acidic juices, and alcohol, and smoking. As published in many international journals, hyperacidity, acid reflux, and GERD lead to heartburn. In hyperacidity, the excess acid from the stomach can move upward into the esophagus, known as acid reflux, as the lower esophageal sphincter, which joins the esophagus and stomach, becomes weak. Since the esophagus is not well protected like the stomach, the acid can irritate the lining and cause inflammation in the esophagus. This causes painful symptoms that can last for a few minutes to hours and can occur more frequently within a week. This chronic form of acid reflux is known as GERD, that is, gastroesophageal reflux disease. The major symptoms of heartburn due to acid reflux and GERD are a burning feeling in the chest, epigastric pain, a bitter or sour taste in the mouth, nausea after eating, regurgitation, frequent burping, flatulence and gas, stomach discomfort, difficulty in swallowing, sore throat and dry cough. The question now is, do regular antacids help? In hyperacidity and GERD, regular antacids can only neutralize the acids, leaving acid reflux unattended. To treat hyperacidity, acid reflux and GERD, Indus Life Sciences comes with a unique third-generation antacid named NewGel, which controls acidity, prevents reflux. NewGel offers balanced combination of alginic acid, magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate, and dimethicone. When a person takes NewGel, the raft-forming alginate physically blocks reflux through a unique mechanism. When alginic acid comes in contact with the gastric acid, the raft-forming alginate, which includes natural algae, begins to form a light but strong foam barrier known as raft. This raft floats on top of the stomach contents and prevents acid from moving upward to the esophagus. The alginate raft formula, containing balanced antacid components, offers a speedy onset of action in less than 5 minutes and provides rapid relief from acid reflux with effective neutralization of stomach acid. New gel has long-lasting effects up to 4 hours, since the raft can be retained in the stomach for several hours. Dimeticone in new gel is an anti-foaming agent. It reduces the surface tension of gas bubbles, causing them to combine into larger bubbles in the stomach, which can then be passed more easily by means of belching. Dimeticone thus relieves flatulence. New gel is recommended in hyperacidity, GERD, gastroesophageal reflux disease, gastritis, flatulence, and as an adjuvant to NSAIDs. New gel is available as New Gel 200 ml suspension and New Gel tablets with delicious mint flavor. New gel is safe in pregnancy. New gel is sugar-free, hence safe for diabetics. For patients with symptomatic pain due to gastric and duodenal ulcer, Indus also presents New Gel O, the alginate raft-forming antacid with mucosal anesthetic agent oxytocin. Oxytocin is a potent, safe, local anesthetic agent that provides prolonged anesthesia of mucous membranes, thereby offering prompt and prolonged relief of pain. New Gel O is available in 200 ml suspension with mint flavor. New Gel and New Gel O. Raft formation reduces intensity and frequency of reflux attacks. Works in less than 5 minutes. Offers long-lasting effect up to 4 hours. Sugar-free, hence safe for diabetics. Delicious mint flavor improves patient compliance. We thank the entire medical fraternity for supporting Indus in our journey towards better healthcare.
I'm starting to share my screen now.
Yeah, it's up, Paul. We're seeing your share now.
Okay, are you seeing my Abbott
We're seeing the Abbott A. Yeah.
Okay, great. It's still morning, so good morning. My name is Paul Russell from Abbott Nutrition, and I'm grateful for the opportunity to present on some Abbott products at this year's World Family Doctor Day conference. Now, Abbott's products. Abbott has a wide portfolio of products covering pediatric nutrition, adult nutrition, and therapeutic nutrition. So I'll just be highlighting a few of these products. So starting with Ensure, first, for the patient, there are several choices. And the key is to find the ideal Ensure to help the patient reach their nutritional goals. So the first Ensure product we're going to be looking at is Ensure Max Protein. Now that's ideal for persons recovering from illness, injury, and surgery, where protein stores have been depleted. It has 30 grams of quality, high quality protein. It has 4 grams of fiber, 1 gram of sugar, and it's 150 calories. It's suitable for lactose intolerance, it's gluten-free, and it's also kosher and halal prepared. We also have an Ensure plant-based protein shake, which is vegan-friendly. It's dairy-free with 100% plant-based protein. It's 180 calories, it's 20 grams of protein, and 5 grams of fiber. So for persons living with diabetes, we have 3 presentations. Firstly, there's Ensure Original, which has 10 grams of protein in only 180 calories. We have Glucerna Hunger Smart, which has 15 grams of protein in 180 calories. And we have the new play on the block, which is Glucerna Protein Smart with 30 grams of protein in 150 calories. So all our glucerinans are kosher and halal prepared, are gluten-free and suitable for lactose intolerance. So for persons who have hard to heal wounds, some of your patients, this can take a toll on them. And whether the wounds are from pressure injuries, diabetic foot wounds, surgical incisions, or other acute and chronic wounds, we have Juven. Now, Juven contains amino acid, arginine, which promotes blood flow, glutamine, which helps with protein synthesis. We have hydrolyzed collagen protein to help stimulate internal collagen production. There's also HMB, which is a metabolite of leucine, which helps with regulation of protein. And there are also micronutrients, vitamin C, vitamin E, B12, and zinc. And the combination of all these compounds they're all vital for wound healing. Juven is recommended for 2 sachets a day to support wound healing. It's mixed with 8 to 10 ounces of fluid or food, and it comes in the flavors orange and fruit punch. And just a reminder, for mild to moderate rehydration, there's Pedialyte. Now we know of Pedialyte as being for kids, but right now, the formulation of Pedialyte is that it provides hydration for all. So whether it's you're exercising, excessive sweating, or extreme heat, or what we know for Pedialyte to be used for, vomiting and diarrhea, there's hydration for all and not just for children. So I've included my business card with my cell number 489-6093. And I can also be reached by email at paul.russell with 1L @abbott.com. And all our products are distributed by CareMed Limited at 20 Lady Musgrave Road. So please make contact with me should you have any questions, queries, or concerns about any Abbott nutritional product. And I thank you for your attention and have a good rest of the conference that you're attending. Thank you.
Thank you so much. Good to hear from you, Paul, on your great products. Thanks for the reminders. I had forgotten Juven. And good to hear from Indus as well. Thank you for joining us and staying the course with the Caribbean College of Family Physicians all the time. It's great. Thank you. Have a good afternoon.
Yes.
Dr. Brown-Morgan, did you want to say something? I see you.
Yes, right. So this is actually when we are going to do a small little 5-minute thing where I'm going to introduce our participants today to Caribbean, to community-based rehabilitation Jamaica, CBRJ. It's the organization that we are actually are funding. This is our project for World Family Doctors Day 2025. This is an organization which functions across the island. It is staffed by persons who care for the disabled population. And these are trained people as well as sometimes parents and community-based, community health aides, doctors, physical therapists, and social workers. And this is a dedicated organization of people who, I have known them to work for months without pay. So it tells you this is not just it's not a regular government organization. It depends a lot on what people will help with in order to keep them going. And more recently, the Monk Street head office came under the threat of closure as the kitchen serving their main facility, which is the Monk Street head required significant upgrades, and there was a threat to close them. And the whole place actually could do with some upgrading. The offices are not looking so well. So we chose them to be our community project for World Family Doctor Day 2025. So I'm asking, we with a donation of $150,000, but this is by far not enough. So this moment serves as a moment of an appeal to those who are listening here with us this afternoon, where I am hoping that I'm going to share some information on them with you, and I am hoping that you will donate something if you can, anything. It could be $1,000 Jamaican dollars, it could be $5 US, it could be a couple thousand, it could be 50,000, it could be 10,000, it could be 2,000, it could be 500 US, it could be 50 US. Please, in this moment, think about these young disabled children and also through to adults that this organization serves, and the fact that they are being threatened and they live under these moments of threat. So, yes, I'm being asked to say that I'm speaking in English. Okay, right. So, Sama, we're on our first slide. Yes, so CBRJ is a non-governmental organization. It was formed in 2011, and it's a merger of rural services for children with disabilities and 3D projects. Often you'll hear me refer to 3D projects, because when I knew this organization, it was 3D projects formed by Molly Thorburn, who's one of our great doctors here in Jamaica who dealt with children with disabilities. And the two organizations linked together and formed one. Next slide, Sam, go ahead. So they provide services for children with a variety of problems, intellectual disability, physical disabilities, autism. We are seeing at our clinics there, where I sometimes help. The autistic children, they dominate now the clinic load. And we have problems with children with speech, hearing, visual impairment, and medically, many other conditions as well. Thank God we're not seeing cerebral palsy to the extent that they used to see them there. And next. Right, so as you see, services for over 600 children in St. Catherine, Manchester, St. Elizabeth, and St. James. And this is what is under threat now. And this is why we're seeking to try and make this appeal. Next. Okay, that's me helping them. That's me in a clinic. They shared a picture there where we see, you notice I'm looking at a baby. That baby cannot sit up. Probably over age 3, cannot sit up, cannot talk, but the parents are still so involved and so, wanting the best for this child. And it is up to us in the society here to give them what we can, because they're often very poor, these parents, and very, very much unable to afford any of the care or the needs, the tools that we would like to use to help their children. But we do these assessment clinics throughout all the parishes. And also there's assessment by physical therapists and occupational therapists. Go ahead, Mom. So we have the developmental screening. Next, please. And many children have multiple disabilities. So they're unable to attend school and their regular school and even care, because the amount of money, as you heard Dr. Edemeyer, Professor Edemeyer speak of before, in getting a child like this to school, who cannot take, no matter the age, transportation by themselves. So you're looking at 2 people all the time, the pay. and also may not even be able to sit by themselves. Next. Advance, Sam. So, because they cannot come to us, we often try to go to them. So we have the CBRG community health aid workers who try to do community visits. This has been hampered very much because we don't have any transportation anymore. The old minibus that we used to have cannot be used anymore. So one of the things that these folk need, and I always refer to them as us because Molly Thorburn involved me in this many years ago in her lifetime. And her passion for this group of people became my passion for them. And it is very distressing that her own efforts, which have now expanded across this island, would be threatened with any form of closure. So, and the thing, our rehab, we try to visit and do the rehab in the home of these patients, these youngsters whose family just cannot find the wherewithal to travel with from their distances, and it's 2 or 3 of them. Go ahead for me, please. Advance. The other things that we need for these facilities of CBRG is anything. We need food items, we need clothing. So anybody with a store, one of these stores that has things that they're not able to sell and that they normally would even give some elsewhere, please remember that CBRG is open to receiving some of these goods. Clothing, educational books, toys for these children, and of course from our companies, pharmaceutical companies, sometimes medication under the supervision of the doctors. And we have in the past received some medication from like epileptic form treatment medications from some drug companies here in Jamaica. I will mention that in the past, MSN had done that for us. Advance for us. Next. Oh, I see diapers as well. Now this slide, can you please, those who are interested at all, the doctors who may have patients that they've wondered, who or where can I send these children for assessment? Because remember, this clinic also does assessment. It does the psychosocial educational assessment that is required to advance these children into some of the government facilities, School of Hope and places like that, where they can indeed be formalized into the system. And also, this body, CBRG, has its own schools. It's always associated with these more than daycare, because the teachers there are trained in the care of these disabled children. So please take a picture of this slide. Please take a picture of this slide so you know where some of the main facilities are located. In Monk Street, Spanish Town, in Linstead, St. Catherine, and this also has about the adolescent adult care program, Monk Street. But we also have access, of course. The Mandeville is not here, and the St. Elizabeth is not shown in this slide, but there are clinics and preschool facilities throughout. Go ahead, Sam. There, each center provides preschool programs and for children with disabilities, preparing them to transition to other learning institutions. Advance, please. And we also have an adolescent adult program because, children grow. And what do we do with these children? often there is nowhere formal to send them. So we try at CBRG, they try to train them as they are able to a certain amount of independence, with whatever they can do. I remember once when they were doing bookmarks and also when they have done painted river stones with flowers and little messages, beautiful things that people could purchase. So thank you, and we advance again. Yes, Dr. Gordon. It is an NGO facility, but it is very, very, very much in need of care and memory, social memory of those who count. We try to get adaptive assistive aids when we can. We have various organizations that will send wheelchairs and from time to time, which we will then get in touch with the membership there. The children need to come in and see if we can give them that. Next. So parents are also trained in being a part of the organization. We try to have meetings of the parents where they're exposed to each other. They can share their thoughts, their experiences, and also they learn how to care for the children. Next. And there's training also. The government does have training sessions to which we send these members. Yes, Dr. Gordon, fallen off the radar of the government. But you know, it's not just them. There are others that have more, I think, are more prominent, give more prominent assistance. And I think that this organization is in need maybe of I don't know, we need to, like some of these organizations have mentors, a big mentor, a big name to bring it to the forefront. Next slide, please. There we go. Support our children with disabilities, make a difference in their lives. Thank you. Now remember, you can help us through using when you registered, there was on the registration, you see CCFP, an account number. You can give to that account number whatever you can, and you can then take a photo and send it in by email so that the funds are put aside for CBRG. I thank you very much for this time. I might have gone slightly over, but thank you so very much for the moments.
Dr. Brown Morgan, thank you. We can hear the passion, and we indeed know of your passion and your years of dedicated service to the 3D projects, etc. Thank you for your work, and we really hope we can build momentum. Thank you for bringing this into highlight, and we have to see how through CCFP, AGPJ, etc., and other social media means as is being highlighted, we can really push it out to the attention of our communities. Thank you, Dr. Brown Morgan. We are over time, but that's okay. We'll try to catch back up, not cutting into any one time, but next on is Dr. Kian Booker, who we know, I know very well, holds a postgraduate degree in family medicine and works full-time as a lecturer at the University of the West Indies. She's worked in both the public sector and the private sector. She believes in the power of community as no man is an island, indeed. Her favorite pastimes include gardening and painting landscapes. Dr. Kian Booker is going to bring a presentation, I think is based on her work, looking at the knowledge of physicians regarding the provision of care for adult persons living with physical disability in Jamaica and the challenges that they experience. So we're ready for you, Dr. Bukal. Sorry for the delay. Kian? Oh, great.
All right, good afternoon. Yes, good afternoon, everyone. Let me just set this up here. All right. Okay, so when you hear the term special needs or disability, what comes to mind? Well, this is a question that I ask my students at the university, and often I get responses like burden, needing more help, financial crises. So what is the definition of disability? Well, according to the World Health Organization, disability has 3 dimensions. It is 1, impairment in a person's body, structure or function or mental functioning. And examples of impairments include loss of a limb, loss of vision, or memory loss. It is activity limitation, such as difficulty seeing, difficulty hearing, difficulty walking, or problem solving. It is participation restrictions in normal daily activities such as working, engaging in social and recreational activities, and obtaining healthcare and preventative services. So then disability refers to the interaction between individuals with a health condition, for example, cerebral palsy, Down syndrome, and depression or schizophrenia, and the personal and environmental factors. And these include negative attitudes, inaccessible transportation, inaccessible public buildings, and limited social supports. We have 2 models of disability. We have the medical model, which we are all used to, and we have a biopsychosocial model of disability, which recognizes that disability is not an attribute of individual people, as conceived by the medical model of disability, but instead can result from environmental barriers, for example, inaccessible buildings that impede disabled people in their daily lives. Thus, disability becomes a human rights issue and a social justice issue. And I do wonder, how are we in Jamaica managing this area of social justice? Over 1 billion people in the world experience some form of disability, with almost 80% of that population being in the low to middle income countries. And there is great disparity in the equity and accessibility of healthcare for those who are disabled. So how do we as a medical fraternity care for those who are differently abled? It is documented, unfortunately, that persons with disabilities are not recipients of the best quality of healthcare. In fact, the World Report on Disability states that persons living with disability experience barriers to health care, and these barriers include the prohibitive cost of health care, limited availability of services, physical barriers, and inadequate skills and knowledge of service providers. There also have been studies indicating that most physicians feel ill-equipped to manage patients with disabilities. In fact, one study showed that people with disabilities were twice as likely to find healthcare provider skills and equipment inadequate to meet their needs, 3 times as likely to be denied care, and 4 times as likely to be treated badly by their healthcare providers. A physician's attitude also does affect the relationship building and participatory decision-making by patients living with disability. It's been documented that false assumptions are made by us who have negative biases concerning the lifestyle of a person with disability, thus leaving their needs unmet. But why do we care for the vulnerable? I like these quotes. A society is measured by how it treats the weak and vulnerable, and we must strive to build a culture of life, as well as the measure of a nation's commitment to the sanctity of life is reflected in its laws to the extent that those laws honor and defend its most vulnerable citizens. So how are we treating our most vulnerable citizens? And why do we care for the vulnerable? I like to tell my students that we're not invincible, right? It could be any of us one day. All it requires is one accident, one drop in the bathroom. Our lives are fragile. One illness, COVID, right? Life is fragile and we are not invincible. So now to the study. I did a study called titled The Knowledge, Attitudes, and Practices of Physicians to and Provision of Care for Adult Persons Living with Physical Disability in Jamaica. I did it for completion of my DM program. And I did it along with Dr. James. And why did we do this study? Because we thought it was important to identify and document the difficulties faced by our doctors in providing care to persons living with physical disability. Also, primary care physicians are usually the first contact persons with those with disability, and it is hoped that this documentation may inform actions to respond appropriately to the needs of persons with physical disability and to provide quality care to them. So, primary care for adults with physical disabilities, perceptions from consumer and provider focus groups. The study showed that there was a need for training primary care physicians. And the type of training requested by the providers included how to access disability resources, coordinate care and adapt health maintenance visits, address sexuality and contraception. And there were challenges related to the attitudes of providers of care. To quote the article, professionals' cognitive and attitudinal barriers cause further difficulties, and most consumers reported encountering misinformation, lack of knowledge, or prejudice by their healthcare provider. So access to medical care not only involves the geographical location of medical centers, but it also involves the physician's attitude towards persons living with disability and the physician's expertise about the natural course and typical complications associated with a disability. And I do wonder, how do we fare in that regard? In a report on the situational analysis of children with disabilities in Jamaica, it was stated that the prevalence of disability in Jamaica was 3.3%, with most persons living with disability being in the lower socioeconomic class. It was also stated that only 26.6% of persons living with disability self-report that their health was good. In contrast, persons without disability amount to over 85% who describe their health either as being good or very good. Dr. J. Moncrief did a study as part of background data for the Jamaica Council for Persons with Disabilities. And she found in there that of the 127 healthcare workers who participated, 54% knew nothing about the National Disabilities Act, and 78% knew nothing of the Jamaica Council for Persons with Disability. So in this study, it was a cross-sectional qualitative study that was done. And we targeted physicians in Jamaica who work in primary care settings. And they should have been working for at least 1 year. So we targeted all physicians fitting the study population eligibility criteria. And this was to facilitate the obtainment of an adequate sample size. As the survey was online, a low response rate was expected. So essentially we had a questionnaire, and at this point, I would have to thank the CCFP, the AGP, as well as the Medical Association of Jamaica for sending this questionnaire out to you guys. And I thank you for responding. So essentially, the questionnaire asked questions about demographics. We also asked how long you were practicing medicine. We asked things like, does your office have doors wide enough for persons to enter with a wheelchair? Do you have beds that can move up and down to facilitate persons who are have restrictions in their mobility? Are you aware of the law governing how we interact with persons who are disabled? So those were some of our questions. So what did we find? Well, a total of 221 physicians responded to the survey, yielding a response rate of 17.3%. 28% were male, 72% were female, and the age, well, 25% were in the 31 to 35 age group, and another 24% were in the group who are older than 50 years. And the highest level of education obtained by respondents were the MBBS, as well as 36% of respondents had a Doctor of Medicine degree. So in terms of knowledge, the knowledge question that we asked was regarding the Jamaica Council for Persons with Disabilities, as well as the Disability Act. And we found that 75% of physicians were aware that the Jamaica Council for Persons with Disabilities does exist. However, 68% were not aware of the resources offered. Of the 221 respondents, 91% have never read the Disability Act, although 82% did say that they knew that the act existed. And in terms of practice, we found that persons in private practice, 78% did not have an adjustable examination bed. In the public medical sector, 76% did not have an adjustable examination bed. We asked the question, do you have doors wide enough to allow for wheelchair access? 84% in the private sector did not, and 78% in the public sector did not. We also asked if there was a ramp in your offices. 16% in the private sector did not have a ramp, and 16% in the public sector did not have a ramp. We also asked persons this question, which they were free to type a response. What challenges are faced by you in treating persons with physical disabilities? And 58% stated the lack of proper equipment and facilities was a challenge. 13% cited lack of family or social support for the patient, and the remainder cited communication difficulties. Some even made comments as it took too long to deal with these persons, and some other persons made a comment that I fear harming them because I do not know what to do. With regards to taking too long to deal with these persons, I remember when I was teaching, because I teach the students about, approaching a person with special needs, and they were relating one story. One of the girls, she's those with hearing impairments, and she took a person to clinic, and there, and they were the last to be seen because she overheard one of her colleagues, one of her doctors saying, who's going to take so-and-so? I can't bother with them because they can't hear. So we really don't treat our persons with disability well. Also in training, 93% of physicians stated that they did not have any specific training for the delivery of care to persons living with physical disability, and 85% of physicians agree that specific training is needed. So what is the conclusion? Well, external as well as internal challenges do exist in caring for persons with disabilities, and education and sensitization of doctors regarding health-related rights of persons living with disabilities and resources available to assist in care is needed. Policy will need to be accompanied by financial outlays if there are to be optimal care for persons living with physical disabilities. So let's talk briefly about the rights of persons living with disabilities, seeing that most persons knew that it existed, but they don't know what it says. And these are the laws governing how we interact with persons with disability. So it stems from the United Nations Convention on the Rights of Persons with Disabilities. And as I said before, disability is an evolving concept that results from the interaction between persons with impairments and attitudinal and environmental barriers that hinders their full and effective participation in society on equal basis with others. The general principles of this convention is respect for the inherent dignity, individual autonomy, including the freedom to make one's own choice, and independence of persons with disabilities. We emphasize non-discrimination, full and effective participation and inclusion in society, equality of opportunity, accessibility, and respect for the evolving capacities of children with disabilities with respect to their right of children with disabilities to preserve their identities. With regards to health, the United Nations Convention on Rights for Persons with Disabilities states that a person with disabilities should be provided the same range, quality, standard of free or affordable health care and programs as provided to other persons, including in the area of sexual and reproductive health and population-based public health programs. They require health professionals to provide care of the same quality to persons with disabilities as to others, right? But what do we say in Jamaica as it regards to health? Or Disability Act of Jamaica 2014 stated that healthcare providers shall ensure that the following are adhered to, that a person with a disability shall have access to the same range and standard of affordable health services as provided to other persons, including sexual and reproductive health services. A person with disability shall be provided with the health screening services required because of that disability, including early detection, treatment, rehabilitation, identification, and intervention as appropriate, and services designed to prevent or minimize further disability. And with regards to health screening services, how well are our mammograms adjustable to help to assist persons who cannot stand? You know, do we forget to screen persons with disability because we're just focused on their disability and not treating them as a whole person? Also, let us not forget our caregivers, because caring for the disabled elderly can create issues such as anxiety, stress, sleep problems, depression, and social isolation, economic issues, as well as physical and emotional problems themselves. So what can we do as primary care physicians? Well, you know, we can create an online support group for the caregivers. It might be difficult to bring the family and caregivers together because they either work or they can't leave the elderly alone. But you can also use social media because it's available, it's cost effective, and there's ease of continuity. We can also utilize the social support systems provided by the Jamaica National Council for Senior Citizens. So the message is, with regards to persons who are differently abled or disabled, we should be patient. We should make more time for them. You want to ensure that your private offices are accessible to them, ramps, have braille signs, learn sign language. The deaf community is underserved. You're not only their doctor, but their advocate. We need to utilize a biopsychosocial model of patient-centered care, and we are not invincible. It could be any of us, any day. So we should treat them with grace and empathy. Thank you for listening to this talk.
Dr. Bukhal, Kian, thank you so much for an excellent, excellent presentation. Just like with Dr. Brown Morgan, your sincerity and passion for this work shines through. Thank you for doing this. And I see a lot of claps coming on. Excellent research study and excellent focus on working with differently abled persons, and especially as it relates to the elderly. Thank you. I am going to make a suggestion, Kian, if that's okay with you. Let's have the Q&As in the text. You're able to stay back with us, Kian? Will you keep
Yes, yes, I am.
Thank you. Monitor the Q&As.
Sure.
Everyone with any comments and questions, please put them in the Q&A session. I am going to suggest that we move on to our next speaker. And if we might have a few minutes for questions at the end of that session, at the end of that presentation, and we can take any burning questions together. Thank you once again, Dr. Bukhal. Let me introduce our next speaker, who is going to speak to us on a very important topic, importance of adult vaccination, especially herpes zoster as a debilitating disease. And our presenter is Dr. Salvatore Ferraro, who is a medical doctor trained in medicine and surgery at the Universidad de Oriente in Venezuela. He specialized in pediatrics at the Central University of Venezuela and further completed a fellowship in pediatric infectious diseases at the Children's Hospital of Caracas. He also holds a superior diploma in tropical diseases from the National School of Health in Madrid, Spain. Dr. Ferraro has extensive clinical experience, including his former role as coordinator and medical consultant for the prevention of vertical transmission of HIV at the Institute of Public Health in Bolivar State, Venezuela. He's actively contributed to scientific literature as a co-author of the Venezuelan antiretroviral therapy guidelines and several pediatric consensus documents on infectious diseases and immunizations. Currently, he's based in Panama, and he serves as a medical manager at GlaxoSmithKline for the CARICOM region, focusing on HIV, antibiotics, and vaccines. Welcome, Dr. Ferraro, and it's over to you. Thank you.
Thank you. Just to confirm, you can hear me clearly?
Yes.
That's right?
Yeah,
okay.
We can hear you.
I'm going to share my screen. Please let me know if you are able to see my screen.
Yes, we're seeing your screen perfectly. Thank you.
Perfect. So I know that I have 30 minutes, so I'm going to take advantage of the time because I have the presentation, the importance of vaccinating adults, and then I'm going to talk about herpes zoster. So this is my disclosure. Currently, I'm working at GSK. I'm based in Panama. I'm a medical manager for vaccine for Central America and the Caribbean area. So I would like to start with this slide, and I'm going to maybe mention Dr. Demaris, the gerontologist, that she's playing very well the fact that Jamaica population is getting elder, is aging, and you have already some demographic change. So as you may know, we are aware that in the 21st century, the societies has already a high proportion of older people, and the life expectancy is around 80 years. And by other hand, globally, this number of older people is growing faster than the number of people in older age group. So as the population is aging, also there is a real concern or increase in focus on healthy aging as being critical to social and economical success in the 21st century. And vaccination actually is one of the component of this. So right now we're going to see some message regarding aging and vaccination. So here I would like to highlight one important phenomenon that has been already mentioned, and the fact, as I said before, the global population is aging, and as a result of effective infection disease prevention in the infancy and early childhood through the vaccination, the greatest proportion of burden disease of vaccine preventable disease is right now in older adults. And I'm going to give you an example. The number of adults who is dying from vaccine preventable disease in the United States is right now 350 times higher than the number of such deaths in children. So having said this, it's important to bear in mind the concept of immunosenescence. Immunosenescence refer to the gradual, as you can see here, to the gradual decline of multiple aspects of the immune system that will accompany the normal aging process and see here as, for example, the number of naive immune cells will decrease. Also, we are going to see a reduction of T cells, B cells, with fewer available precursors and also a high proportion of homogeneous memory cells that are used to be dysfunctional. Also, we are going to see the epigenetic dysregulation in B and T cells. It is thought that contribute to this pro-inflammatory environment, and he also talked about the cancer. And this inflammatory environment will promote the development of chronic inflammation, autoimmune disease, and cancer, as well also will reduce the ability to respond to immune challenge such as infections. And I'm going to show you right now a couple of some examples around infection disease and aging people. As we can see, in the last few decades, there has been a shift in some infection disease that traditionally affect childhood towards, and this shift is toward older age group. And one example of this actually is pertussis. This surveillance data from Australia, New South Wales, Australia, show that the percentage of pertussis cases in children has decreased dramatically. And this is because of the vaccination, the wide vaccination that we have during childhood. However, during the same period of time, the percentage of pertussis cases in adults between 18 to 64 years of age has increased. And the percentage of pertussis case here in adults above year of age also is increasing. This case, as I said before, cases are increasing among the elderly. Hospitalization that it is representing this slide also rise, especially in those people, those who are over 65 years of age, and obviously complication associated with this hospitalization. Pertussis maybe is not the only problem. As we age, there is an increased risk for several infection disease. This is data from US, where we can see that people age above 65 years of age account for up to 70% of the average annual influenza rate hospitalization, up to 90% of the influenza-related death, and up to 50% of the total case of invasive pneumococcal disease. And this is happening even though we have vaccination to both disease, but we know that the coverage needs to be suboptimal. During the elderly, there are also other points that have to be seen, and it's the fact that aging used to be accompanied by comorbidity, chronic common comorbidities. So this used to be more frequent comorbidities after 65 years of age. We can see that at least 80% will have one chronic condition. Here you can see the most frequent. And after 65, at least up to 70%, they will have more than 2 chronic conditions. Right now here you will see which are the most common. So comorbidities also is important to understand that are linked to dysfunctional immune response. And the majority of comorbidity are associated with dysfunctional immune response. In the very specific case of COPD, COPD leads to a chronic inflammation and immune dysregulation, making these people more susceptible to recurrent infection due to the decreased cytotoxicity of peripheral blood natural killer cells, There is also in COPD a reduced phagocytic ability of peripheral blood cell. And also very important is the fact that COPD is considered to be an advanced aging phenotype. And this will obviously associate with more acute exacerbations and worsening of the lung function and an increased rate of hospitalization. Another example is diabetes. Diabetes increased inflammation also is associated with the immune system, potentially enhancing 2 to 4 times the risk of infection. Diabetes also used to be associated with a reduction in cell-mediated immunity and dysfunctional innate immunity that will obviously will associate with a higher risk of infection. Having said this, despite knowing that people with chronic comorbidities, in general, they are going to have immune function in disadvantage compared with healthy person on the same age, we see that vaccination coverage used to be suboptimal. And this occurred in the majority of our country, regardless of the economic and the educational status of the people. And in here, we can see the example of Germany, where influenza, in this case, influenza vaccination, even in people with comorbidity, with underlying condition in gray bars, reach coverage below the established level for that country that used to be, should be above 75% for older age group. So having said this, I will ask you what's the role or what role do vaccines play here? Well, vaccination may, importantly, they help to resilience by contributing to something that is called immune fitness. So as we like to make exercise to be on fitness. Well, vaccination has demonstrated to contribute to this immune fitness. And immune fitness will refer to an immune system that is resilient and capable of adapting to challenge appropriately. And this immune resilience that will be the effect of what I'm saying before is given by the ability to maintain homeostasis or recover health after a stressor or a stress factor like an infection disease, for example. Resilience in the elderly can be modulated through the training of the innate immunity as a result of this epigenetic reprogramming. And on the other hand, through the expansion of the immune system, through the T cells, B cells, that becomes, as I say at the beginning, limit with age. So vaccination, at the end, will positively contribute to immunofitness. And this is something that is just beginning to be understood. So vaccination has also demonstrated that it's a cost-effective and efficient public health strategy to promote healthy aging. And here we can see a number of vaccines that currently are recommended for older adults to promote healthy aging. Some of the vaccines here are recommended primarily to reduce the risk of mortality. Here we have pneumococcus, tetanus, diphtheria, hepatitis A and B when it's necessary, and influenza. And by the other hand, we have other vaccines that used to be recommended primarily to improve quality of life. And here we have important vaccines that are pertussis and more recently shingles. So finally, to end this first part of my presentation, I would like to say that life course immunization, along with appropriate lifestyling and healthcare intervention, will provide an opportunity to live and to age in good health and to provide economic benefits resulting from a healthier, more productive, and aging population. So now I will switch to herpes zoster, a debilitating disease. And I would like to start showing you the classification of this very wide family, the family of Herpesviridae, that used to infect a wide range of animals, mammals, birds, reptiles. However, herpes zoster type 3 here, the varicella zoster virus that I will focus on the next slide, it only infects humans. Humans used to be the only natural host for VCV. And this is very important because the fact that only infect humans has complicated a little bit the effort to understand the pathophysiology of VCV associated phenomena like vasculopathy. So this is a virus. VCV used to be the smallest, it's the smallest of the human herpes virus. It compounds of the four main parts, the lipid envelope, the tegumen structure, then we have the nucleocapsid with a protein shell and a double-strand DNA genome. And this envelope is derived from the cell membrane with glycoprotein. And here I would like to show this glycoprotein spike. It's the most abundant, actually. It's the glycoprotein E, which is the antigen that is used in the recombinant zoster vaccine. And the reason of this is because it's the most abundant glycoprotein that is expressed on the surface of VCV infected cells, and also is one of the most it has also a very it trigger a very important immune response, the glycoprotein here. So here we have the natural infection of VCV, as you know very well. VCV causes varicella during the primary infection, during the primary exposure. And after we have a varicella, VCV establish a latency. A latency here in this area, the root, in the dorsal root ganglia, and also in the cranial nerve ganglia. Remember that affect the fifth nerve, cranial nerve, and the seventh, and also have been shown that can affect the eighth, ninth, and 10th. So this primary infection will induce virus-specific humoral and cell-mediated immunity response through effector and memory T cells. These T cells, specific T cell immunity, will prevent subsequent infections and subsequent reactivation. But over time, with age, and that's why it's important to understand the concept of immune senescence, we're going to have this decline in the immunity. Well, this happens also for specific immunity against VCV. So over the time, as we age, and also under certain conditions that we show you in the next slide, these specific T cells immunity against VCV will decline, and protection will be compromised, leading to the reactivation of this latent VCV that will express as a shingle, as a zoster. Here, very important is that the fact that during this reactivation, the viral replication will result in ganglionitis here, extensive infection also, and destruction of the neurons and supporting neurological cells. That's why the important pain that is triggered after the reactivation. So the infection and this inflammatory response is probably the origin of the prodromal pain that will develop before the rash. And also very importantly is the fact that approximately 99% of adults above 40 years of age have shown serologic evidence of VCV infection, and this will make a prognosis that 1 in 3 people will develop shingles during their lifetime. This is US data. However, I have to say that this data has been replicating in many countries around the world. and the data is very similar. We have done some study, for example, I share some information from some experts from Brazil, for example, and they have 95% of seroprevalence after 40. In Mexico, 95%. And well, even though we don't have specific data in Jamaica, we suppose that this will be the 10 that other countries are close to by. So adults above 50 years of age, an individual with immunodeficiency, or those who are having immunosuppressive condition are the two main population that will be a higher risk for reactivation of PCV. People above 50 because of the immunosenescence and immunosuppression, immunocompromise because of due to disease or due to certain drugs because for obviously reason because the decline of the immunity. Here we have the immune profile. As I said before, the dominant driver of shingle will be age. Age-related decline in immunity that for shingle has been associated when we become older than 50 and patients who are immunocompromised. Here we see, once again, associated with the immune profile, the primary infection that will induce BCV immunity in T cells. We have a sharp rise in T cells, specific immunity. This immunity then will be boosted periodically by exposure to BCV as through natural infection. When you are a doctor and you are exposed to someone who's having varicella, this is a natural exposure that will boost your natural immunization. But also this booster also has been observed with silent reactivation through latency without any clinical manifestation. And this is very important because it has been related to some complication. We see then a plateau in the T cell specific immunity, but as this T cell memory will decline with age or with immune specific impairment condition like immunosuppressive drug or immunosuppressive condition, we'll see that we are going to be a higher risk to develop shingles. So here we have the clinical presentation. Epizoster start with a prodromal phase, which used to be characterized by pain, itching, unpleasant sensations, or sensitivity to touch in 1 to 3 dermatomes. Then we can have also headache, fever. Then we have this last at least between 2 to 5 days. Then the next step would be the clinical expression, unilateral maculopapular rash, that develop on the affected area after a few days, often with pain that can be severe. This pain often has been described as a aching, burning, stabbing, or shooting. Importantly, this can last between 2 to 4 weeks. And during that time, you are going to have this important pain, and now I will talk a little bit more. And then this pain, we can have, then after that period of time, after 2 to 4 months, depending on how many days last the acute phase, can evolve to complication. And here, the most common complication will be PHN, post-herpetic neuralgia. Post-herpetic neuralgia has been defined as a pain that lasts or reappear at least 3 months after the onset of the herpes zoster rash. This is a chronic and debilitating pain. Post-herpetic neuralgia will affect up to 30% of patients with shingles. It is characterized by chronic, strong, excruciating pain in the area where the rash occurs. This pain used to be typically sharp, stabbing, or burning, and may persist for weeks or months, and even years after the rash has healed. This pain used to be debilitating, affecting the quality of life of the people. Actually, postoperative neuralgia is one of the leading causes of pain related to suicide among older people. This is data from US and Europe. And patients with advanced age and weakened immune system are those who are undergoing immunosuppressive treatment used to be the people at higher risk of postoperative neuralgia. Importantly, the inflammation that I referred before caused by the BCV during this acute infection will damage or sensitize these nerves, resulting in this prolonged pain illness. Then we have other non-pain related complications like ophthalmic disease, herpes-zoster ophthalmicus, that could affect up to 25% of the patient with shingles and may produce ocular complication in up to 65% of the case. And most common will be the peripheral ulcerative keratitis. Currently, this herpes-zoster keratitis may manifest alongside with other eye conditions like blepharitis, conjunctivitis, scleritis, uveitis, and retinopathy. Herpes-zoster vasculitis is also a very important complication. This is an inflammation that is induced by the virus, by BCV in the arteries, playing a role in pathological vascular remodeling. It has been observed that the presence of the virus, the BCV, within the sensory ganglia will allow for a transaxonal travel from the ganglia to the cerebral arteries, where the nerve terminates in the adventitia of the artery, as well as to the coronary artery. This process used to be accompanied by increased sympathetic tone, but elevate blood pressure, also altering immunological status. And this mechanism can initiate inflammation and pathological vascular remodeling, leading to vascular failure, arteriosclerosis, microvascular angina, and heart failure inducing by the microvascular dysfunction. Then we have other complications like neurological disease, bacterial superinfections, scarring also, visceral and disseminated disease. So regarding the characteristic of the pain associated with herpes-zoster can vary. Patient may have paresthesia, dysesthesia, allodynia, hyperesthesia. And this, on the right side of this slide, you can see the comparison of the total pain rating index score based on the McGill pain questionnaire for the acute and for the chronic pain. So note that the pain associated with herpes-zoster and with postherpetic neuralgia here on the left side may be higher even compared to other pain conditions such as lower pain and musculoskeletal pain and post-surgical pain. In summary, regarding the pain, I will say the herpes-zoster is a complex neurocutaneous disease, and pain will affect with high impact on quality of life. Will impact physically. For example, we have patients with they want to refer fatigue, anorexia. Psychologically, because most of these patients they will have depression, anxiety, emotional distress. Also will affect socially the patient because the patient used to be isolated, loss of independence, and will affect functionally because they will have breathing issues, bathing, eating, and so on. So regarding the incidence of herpes-zoster, the individual lifetime risk of developed herpes-zoster, as I said before, is around 30%. However, you can see there is a sharp rise after we become 50 years of age when immunosenescent supposed to take place. The incidence and consequently the incidence of PHN also will expect to rise to the aging population and the development of immunocompromised condition associated with aging. Age, as I say many times, is the most important risk factor for herpes zoster, as a compromised immune system. However, common comorbidities also are used to be a risk factor for herpes zoster. Common comorbidities as a COPD, as a cardiovascular condition, such as asthma, diabetes, depression, chronic renal disease. And the main reason of this is because comorbidity used to have immune dysfunction. And comorbidity used to be related to accelerate immunosenescence phenotype. So when it comes about current herpes zoster treatment, we know that antiviral drug used to be effective, reduce the acute pain and the rash duration. But to be effective, antiviral should be administered within the first 72 hours of acute symptoms, which sometimes, I would say majority of the time, used to be very difficult because of the delay of patients seeking medical advice. Then, when we have already established the disease and we have to manage the pain, patient used to be treated with drugs that are used to be active against common anti-inflammatory drugs, they don't work. So they used to be treated with drugs that used to be active against neuropathic pain. And several times, this option used to be also suboptimal and commonly involve a high degree of polypharmacy. Finally, we have prevention vaccines. Vaccines fill this unmet need for the prevention of this disease and complication. Initially, we have a live attenuated vaccine that in Jamaica wasn't in commercially in your country. But this live attenuated vaccine was contraindicated in immunocompromised patients and also show a limited efficacy across older age groups. So finally, in 2017 was launched a new vaccine, a recombinant zoster vaccine. Since that date, in 2017, this vaccine has been used in a very important number of patients of people, and then in 2018 was approved in Europe. And right now there are more than 45 countries that are where the vaccine has been registered. So this recombinant zoster vaccine was elaborated in order to address population-specific challenge, improving the immune response and the prevention of shingles in people older than 50 years of age, and also in people who are immunocompromised above 18 years of age. This vaccine was thoroughly investigated in 2 large pivotal phase 3 clinical trials, SOI 15, SOI 70, in adults aged 15, 70 respectively. Those studies were randomized, observed, blind, placebo-controlled, multinational, multi-center, conducted in 18 countries worldwide. There were more than 29,000 people that were participating, and then they received 2 doses by intramuscular injection, 2 months apart of either the vaccine, 2 doses of the vaccine, and 2 doses of placebo. In this case, the placebo was 0.9% saline solution. And the primary endpoint were the efficacy against confirmed cases of herpes zoster in each study. There were also secondary endpoints, but because of the time, I will go through the presentation. So both studies show a high efficacy against shingles and also PHN and other analyses. In adults about 50, the main efficacy of herpes zoster was 97%. This is data after 4 years where the trial were initiated in the older population, and 91% in adults above 70 years of age. And as you can see here, the vaccine efficacy against herpes zoster was maintained across all age strata examined, include those above 80 years of age and older. Here we can see a very high efficacy for this group of age. And these are the result of long-term follow-up, zoster 049, that evaluate the long-term efficacy and safety and immunogenicity conferred by the recombinant zoster vaccination. And the vaccine efficacy against shingle 1 month post the 2 dose up to 10 years is almost 90%, 89% is the efficacy after 10 years we administer the 2 doses of the vaccine. So regarding safety, the most common or frequent reported local symptom were pain. This is an adjuvanted vaccine, so the vaccine will produce some local reaction. The most common will be pain, but also redness and swelling. And then we have general reaction. This local reaction used to be transient with a median duration from 1 to 2 days. And regarding general reaction, the most frequent reported were myalgia, fatigue, headache. In general, these adverse events used to be transient with a median duration of 3 days or less for any grade. And regarding the incidence of serious adverse event, death, and potential immunity-mediated disease, they were similar between the group that were vaccinated here in orange and the group that received placebo. And this was similar for all time period that was analyzed. So as a summary, I would like to highlight that herpes zoster results from the reactivation of VZV, viral varicella zoster, and is spread from single ganglion to nerve tissue to correspond dermatome. The most common complication of herpes zoster used to be postherpetic neuralgia, which is a pain lasting for more than 90 days after the onset of the rash. It can even persist for years and can be incapacitating and excruciating pain. In elderly patients, herpes zoster may lead to loss of independence and inability to maintain lifestyle, interest, or activity level. Available treatment options for herpes zoster, which include antivirals and pain relief, has several limitations. And finally, herpes zoster and complication can be prevented by vaccination, thus improving the life of older people and reducing societal impact. Thank you very much for your attention.
Excellent. Thank you so much, Dr. Ferraro, for a very, very comprehensive and a very informative presentation, both on the need for adult vaccinations, as well as your reminder on herpes zoster. Very excellent presentation. Thank you so much. Dr. Ferraro, there are a couple questions in the Q&A. And we are 15 minutes over time, which is not too bad, but I know it's a Sunday afternoon and the panel is for session 3 is waiting. Would you be able to respond in the Q&A section, please, to the comments?
Yeah, you mean that I type the answer?
Can you type the answers?
Yeah,
So
sure.
Yeah. Thank you so much, because that way everyone can see the responses as well. And we will move on to session 3. Is that okay, Dr. Ferraro?
Thank you very much for the opportunity to be here with you. Thanks a lot.
Thank you. Thanks so much for your talk and your time with us. Thank you. Thanks, team and colleagues. We will move over to there are some very nice questions in the Q&A, so we'll keep an eye on that as well as we move seamlessly into session 3, and I will be handing over to Dr. Pauline Williams-Green to lead us into an exciting finale of today's conference. Thank you, Dr. Williams-Green.
Thank you so much, Prof. Monica. It's just a joy to see you and to hear you as well. We have had an awesome morning, and Dr. Ferrari really carried us into a very interesting realm. So we want to thank him and all the presenters. But we have to get going because we have a panel of persons who have prepared to present to us on the topic public-private sector partnership, the relationship between the Ministry of Health and the private public health system. Don't we want to know this? So we have presenting to us Dr. Tamu Davidson. And is she online? I think I saw her name somewhere. There you are, Tamu. So we have Dr. Tamu, Dr. Orville Nemhard, who is ready and raring, Dr. Garth Rattray, another person raring, and of course, Dr. Anna Brown Morgan. I'm going to just briefly introduce them for those who don't know these individuals. So we start with Dr. Tamu Davidson. In the interest of time, I will not read everything, just to let you know, she is the director of the Non-Communicable Diseases and Injuries Prevention Unit at the Ministry of Health and Wellness. And she has 27 years of experience as a general practitioner and public health specialist. And we move on to Dr. Orville Nemhard, who is also a public health specialist, having done his master's at the University of the West Indies, and also very much strides the private sector, since he is the founder and director of Health Plus Associates. And again, in the interest of time, we'll move on. And of course, Dr. Garth Rattray, and we know him as the silver pen man who writes in the papers. But I think one of the things I learned when I read his bio, I didn't know he had written a book, The Long and Short of Sick and Thin. I need that book for my next birthday. Garth. So Garth is a graduate of our university. And have I left? Oh, Anna. And Dr. Anna Brown Morgan, who spoke to you very passionately about CBRJ. She's a family physician as well. And she's so involved in CCFP. And she is the most, I was going to say protagonist, but she's the person that pushes us to get the World Family Doctor Day going every year. We really want to welcome this high-class level of this panel, and we're going to ask Dr. Tamu Davidson to start with her presentation. Please stay within the 15 minutes, preferably 10 minutes. Dr. Tamu Davidson, please go ahead.
Yes, my apologies. I hope I can maintain I'm going to turn my camera off. I'm having some challenges with my internet, and I'm actually presenting off-site. Thank you for this invitation to the Ministry of Health and Wellness. We're certainly delighted to partner with you with this presentation today. Thank you. So I will be giving you a general background, just touching on, generally a snapshot of the Jamaican health system and our strategic direction with respect to the Ministry of Health. I'll go into the public-private partnership and some examples that we have been involved in. So right into the background. So as you know, our healthcare system, we have our public and private public healthcare system. We have a no user fee policy. And what that essentially means is at the point of care, you don't have to pay for that care. And that is right through our network or 4 regional health authorities. And within that network, we have our private services, which are fee for service. And those involves our hospital, our doctors' offices, pharmacies, our labs, diagnostic centers, and other professionals complementary to medicine. We estimate that about 50% of patients in their primary care visits are in the private sector, but for inpatient care, majority of that is within the public sector. Now, the Ministry of Health has a 10-year vision for health or 2030 plan, and that plan sets out the goals and the health outcomes that Ministry of Health is working on with other ministries and stakeholders like yourselves that are here today. We have about 8 health impact goals and 6 strategic goals. But there are 2 guiding principles that I wanted to pull from the plan, and one is about equity. So striving for fairness and justice by eliminating differences that are unnecessary and avoidable. And so that is important guiding principle around collaboration and collaborative, the application of collective experience and knowledge of internal and external partnerships, and responding to those shared challenges and goals. And so having a public-private partnership is essential to meeting those goals. And I just pulled out those 2 guiding principles. Here, I just wanted to highlight, I'm not going to go through this, but there are 8 health impact goals, which cover safe motherhood. It covers reducing mortalities and morbidity due to NCDs, your communicable diseases, looking at the whole issue of quality of health care, HIV/AIDS, congenital syphilis, transmission of HIV and congenital syphilis. As you know, we would have eliminated that. And then your neglected infectious diseases and your vulnerable population and health emergencies and disasters. So it covers a wide range of health impacts. And here are 6 strategic goals that the plan envisions will get us there to really meeting those health impacts. And this is shared because in looking at our partnerships, this is going to take a whole collective action for us to be able to do this. So it includes looking at comprehensive equitable care, to financing of care, to leadership and governance infrastructure, and the intersectoral collaborations to address the social determinants of health, and then dealing with human resources. So embarking on this implementation of this vision, the Ministry of Health and Wellness has been undertaking our own healthcare reform, our primary healthcare reform, using the life course approach and having a more integrated, holistic approach. So going, as I said, from the womb to the tomb, but delivering basic package of care right across the life course, the different ages, and you're looking at aging today. And we have also been working on or improving our secondary care model. So we are looking at developing and strengthening a whole network of care, so people move seamlessly through this whole network of care as we work together. So what is this PPP, or public-private partnership? And I'm just sharing this particular definition that I liked from this particular article, but it's a voluntary cooperative arrangements between 2 or more public or private sectors in which all participants agree to work together to achieve this common goal or purpose, to undertake a specific task and to share risk and responsibilities, resources, and benefits. So the flexible nature of PPPs provides us with a framework for developing and adapting existing structures to meet the specific needs. And in this case, it may be a need to provide more primary care services. Someone talked about immunization earlier, and I will mention that later. So why PPPs? You know, there's a rising demand for healthcare services. We're looking at aging, and we know that there's a boom and explosion and a demand. We have limited public resources. PPPs provide shared responsibility, might improve efficiency. There's a need for standardization of care and delivery of high quality care. So we need to ensure that if you're the standard of care in the public and the private are at the same minimum level. We need to monitor care. Also, we want to meet our universal health coverage, and I'll mention that later on. And we want to facilitate meeting our public health goals, and such as immunization coverage. Now, there are many benefits to PPPs. We can improve our quality of care through this arrangement. We can increase access and service coverage. We can reduce the strain on the public health facilities. And it also can help to enhance our disaster responsiveness and preparedness. And it also drives innovation and efficiency through this type of partnership, especially in small island development states. So these are some of the main types of PPP models where you have your service delivery contracts. So private providers deliver health services under a contract with Ministry of Health and Wellness. Things that we have done is outsource our radiological services, treatment of patients with chronic illnesses, which for diabetes, hypertension, HIV, or immunization as well. We have our doctors that do immunize, and we provide the vaccines to our doctors under the health department, and they in turn will report on the immunization. So those immunizations
Oh dear, have we lost Dr. Davidson? She did say there was a problem. Sam?
Right here, I think, as you said, I think the internet problems that you mentioned might be what we're facing. Heavy rains in Kingston, depending on where you are. Hey, Dr. Tamu, can you hear us? All right, Dr. Tamu is probably not hearing us. Do we want to go to the next panelist? There we go. Yeah, it seems like she
I
lost her
ask you,
internet.
Lynn, to call her and see what we can do. But in the meantime, we'll ask Dr. Orville Nemhard. Is she
just
back?
got back. Yes,
Oh,
sorry about
okay, great. Go on. Welcome back.
Yes, so I was going through some of the main examples that we have of PPP models. And so we also use shared use of facilities as well, outsourcing support services that we use. And we also have digital health telemedicine, and then supply chain or pharmaceutical delivery. And so most people would be familiar with our NHF partnerships with retail pharmacies. So these are some examples of existing or PPPs that we have done. Our NHF drug access program with our retail pharmacists, improving access to medication, subsidized medication to the population. When we had our COVID-19 testing, we had our private labs that we engaged, diagnostic imaging as well. We had a private partnership to really get imaging services that were not available for public patients to access those services. Or lab services as well. In most of our health regions, we do outsource our services for pap smears. That's an example to improve the turnaround time for those smears. Public blood donation drives and immunization that I mentioned earlier by our private doctors, and that impact is really to improve the immunization coverage. No, we also had and still have, which we're winding down, our public-private partnership for NCDs that was launched in 2020. Essentially, that was around the COVID period, and it was to ensure we provide essential primary care services for clients with diabetes and hypertension, accessing routine care within the public health centers. That continues. At this time, we are winding down that program, as we looked at the cost benefit and the need for it, the cost benefit seems to lean towards having this program mainly run in the public sector. And just to highlight in the case of disasters as well, and just to highlight Beryl that went before, very often we have to pull on private health facilities to provide additional healthcare support post-disaster. And this, I wanted to highlight our health system strengthening project, where we're actually implementing a chronic care model that was developed of care for NCDs, but will expand to other types of NCDs. And in here, this is creating a network of services for patients to move through patient pathways. So we're not just thinking of primary, secondary care, but a network right within that particular parish, which would include and look at the private sector as well as part of that network. Now, with all said about PPPs, there are challenges. Service quality variance, referral and feedback gaps. So with the service quality variance, you'll have, and this is something that we have seen in the work we have done in evaluating some of our PPP, that we need to establish and enforce uniform standards. So as part of our PPP for NCDs, for example, we do audits of both the private and public to ensure that the care is at the minimum standard. Referral and feedback gaps. So the need for integrated health information systems, and we hope that this is a vision for the Ministry of Health to get to, and we hope we move closer to that. Data security and EMR compatibility. So ensuring that that is important as part of any health information system. The financial risks that are associated with the arrangements as well with the PPP. So they have to be clear contracts and risk sharing mechanisms. And so that's something that we have worked through with our PPP for NCDs and recognize as very important. And then there could be lack of policy coherence. So the practice we find in one setting may be quite different from the standards that are set at national standards. And there are various reasons. Sometimes people are not aware of what these standards are, even though they're accustomed to be practicing the way the standard they were trained in, depending on where they were trained and in what jurisdiction. So there are many benefits to PPP arrangements, and I guess we'll hear this through the panel, but you may have more referral options, faster diagnostic, quicker decisions. You share the burden of the workload that's distributed, but also having a smoother transfer of care for your patients. So our greatest success is when a patient transitions seamlessly from your office to any level of care, either whether it's public or private. So we talk a lot about standards of care, but we're now looking a lot on patient pathways of care and within the public sector, but also the private sector. How does a patient move through care seamlessly? So our PPP is aligned with the national development goals to have a stable and healthy population. Our Ministry of Health vision for 2030, and our universal health coverage. Ultimately, this is where we are to move towards, and this is our strategic vision, so that all people have access to full range of quality health services they need when and where they need them without financial hardship. So collaboration is essential for any sustainable health systems, and this is, set out in our Vision 2030 and the Ministry of Health. You are central to the future of integrated care. So this is our focus in part of our chronic care model and our care in general, holistic care, where you move seamlessly through your care and you don't show up moving from this disease-centric type of care course approach. And so let's work together to ensure quality and equity in health. And the patient's journey should not depend on whether the facility is public or private. We want to get to that vision. And a resilient healthcare system isn't built by one side alone. It takes trust, coordination, and a shared vision between the public and private sectors. Together, we don't just treat patients, we transform lives. Thank you.
Thank you so much, Dr. Davidson, and presenting the public health perspective. And I think showing that is something that we have to cooperate. Now we're going to ask Dr. Orville Nemhard to speak. You're not, you're still muted, Dr. Nemhard.
All right, yes, sorry about that. I actually lost your last few comments. You're asking me to comment on?
No, I would like you to go ahead with your, Dr. Davidson presented the viewpoint from the perspective of the, as a policymaker in the public health system. What is your take on the public, the private-public partnership? Where should we be going in this regard?
All right. I was actually pleased to see the last couple of slides which talked about collaboration and coordination. But the question I have is, where is the forum in which we get an opportunity to exchange concerns? Because I see nice policy statements, but as I say, where the rubber meets the road, sometimes there are a number of gaps. So even things like protocols and policies, which are promulgated in the public sector, we are not privy to them. We have no access to or a regular mechanism for seeing when these updates take place. I'll give you a quick example. There is a document circulating out of the university here now about COVID outbreaks. And it speaks to the protocol for current management of outbreak of practitioners who are infected or patients who are infected. That protocol I've never seen, which speaks to what Ministry of Health says should be done. So I went online and looked. There's a clinical management page in relation to COVID-19. When you click on it, it says the site can't be found. There's another one, which when you click on that, it speaks to recent events in which the minister is talking about condemning the violence against the nurse, which took place recently. Nowhere in there is that protocol that is outlined in the University of Health document for managing patients. There's a mention of vaccine coordination. We do immunizations, we get vaccines from the Ministry of Health. Recently, we have found we've been limited in terms of IPV vaccine that we get. Could not understand why. When we checked it out, we were told that it's because we have been giving the IPV to adults and it's for children. But there's a demand from adults who are particularly those who are migrating. So here we are, we said we're 50% of what we see, 50% of the public health cases end up in the private sector. Here we are with a demand, but we're told that we can't fulfill that demand and there's nowhere else to source the IPV. What is it that we're supposed to do? To whom can we have direct that discussion to have some resolution? Two other things I'll mention very quickly. Occasionally, we can't get drugs in the private sector. I've had the serious misfortune of having a 3-year-old in my office fitting, and we have no diazepam in stock. Not because we haven't tried to get diazepam, but we've been told that the diazepam, when it came in, was bought entirely by the public sector, and there was none in the trade. And that's not the only thing. Occasionally that happens with B12. Sometimes that happens with penicillin. Who can we have this discussion to say, well, what is the need for the private sector and how can we fulfill it so that we do have this collaboration and that we don't feel as if we're in fact, you know, as I always say, feel like the outside children. Never mind, we're seeing 50% of the cases in the public, you know, in the primary care system. So those are just 2 or 3 issues I raised. The feedback from hospitals and our ability to get information. In fairness, I've spoken with somebody in the ministry recently who said, yes, this is something that's coming, but until it does come, very often we're pulling teeth to find from the patient what happened because we're not getting a referral. We're not getting results back. And we're left to try and figure out from the prescription what might have been the diagnosis, what may be the way forward, what further investigations may need it. So for me, public-private is great. I'm all for that. But how do we find common ground whereby we collaborate fully and are able to exchange information and benefit each other, as is said in the presentation?
I think, Arvid, you highlighted two very significant points. So if we are going to share, where is the forum? So we really want to have some discussion on that. We're going to still stay in the private sector. It's not 3 against 1 deliberately. It's just that we can get a wide, you know, we're trying to reach out to more private persons because we don't often get them to speak. I mean, I would like to hear from the public, but we're going to hear from Dr. Gas Rattray, and then I follow with Dr. Anna Brown Morgan. Please go ahead, Doc.
Okay, thanks, Doc. Can you hear me? I can be heard? Yes.
Yes. Okay. I'm sorry. Yes.
Oh, it's okay. So Dr. Davidson gave a very good presentation. It was better than I thought it would be. Dr. Nemha Rose brought some points forward that I fully agree with, but I want to add a few things to it. I agree with him that the private sector physicians are not really welcome, it seems. For instance, I tried to quickly at a patient I had who went abroad, got a massive MI, came back in vegetative state. I got on the KPH ICU. I went to look for her, the physician, and I was told I had to go and get a pass from a crowd of people around this security place. And I saw a nurse. I asked her, could you help me? She said, join the line. That was the end of my trying to go to any hospital to try to help out. Because when you try to call, you can't get through. I had a patient who died recently, Scranton Hospital. When I called nurse and said they couldn't share my number with the doctors. So there is no connection between us physicians and the hospital doctors. And as Dr. Nemha said, as for reports, you can forget that. Because it's no continuity. You have to ask the patients, what did they say? What did they give you? What is this? What is that? Call the pharmacy. It's horrible. So if you want private-public partnership, it begins there. I mean, you spoke about the PPP for NCDs, but before that, I want to say something to you. This PPP started 2015, officially, but unofficially started when the government introduced the no user fee. They called a meeting at University Hospital for us. And then SMO was there, CMO. And she asked us to help out because there's a rush on the clinics. I don't think any of us really. It was so nebulous. You couldn't get in what they're going to do, how they get paid. It just finished. Nobody actually could commit to helping the government when they needed help. So when this PPP thing came in, I was one of the people they used for a, what do they call it now, a kind of project to start off. And I had to basically say, beg pardon and excuse myself. It was horrible. The government said, okay, they want me to be part of this thing. And I said, okay, to help the government, I'll do it. And I must confess that one of my colleagues working with the government said, Garth, don't do it. You don't know what's going to happen to you. I said, but I'm helping out the government. 2 van loads of NH, the government, Ministry of Health people came to the office, 2 van loads of them. I was invaded. They asked to see dockets, to look at my dockets. They want to know my office procedures. And so office with a fine-tooth comb. They gave me 0 for sanitation because we were using bleach. Oh, you must use hydrogen peroxide. Who told us that? They looked to see if I have water tanks. I have no water tanks. We have 3 1,000-gallon water tanks, and they gave me 0 for that too. And so on. I was furious. So I said, no, I'm not going to punish myself. Then they said at first that just to follow up on people with diabetes and hypertension, then we got this thing about doing full physicals and reports every day. No, so I'm really surprised that people are still doing it. I have a patient with a physician who did it, and she said she spent a few $100,000 to upgrade for what she was told they needed. And in the end, she got 1 single Dege patient. I don't know what she does. She was just beside herself. If they want us to do something, tell us first what they expect of us. Plan an appointment to come in and look. Don't just jump on a day when we have patients there waiting. That if something was wrong, patients thought, what's wrong? What happened, doc? Did you do something wrong? So, that was a big turn off for me. Now, a point I want to make is that people who are in private sector, let's say they investigated part of it. They tell me that it's hard to get paid. They tell me that they're owed a lot of money. So I don't know, maybe I'm reaching and saying that when you hear about equipment breakdown in the government system, is it because they're not paying the contractors or whatever? I don't know. I'd love to know this. Why is it that you're hearing this breakdown, CT machine not working? Maybe it's because they're not getting paid. Government theory, right? They pay you when they get a chance to pay you. So those are my concerns. But I must say, Dr. Davidson gave a good presentation, other aspects I didn't think of. So that was good. But there are things that you cannot get a partnership treat us like this. We're not part of the thing. We treat it like we're outsiders. Really, I decided I have never gone then to look for any patient anywhere. I said, no, I don't do that. I don't try to call patients, to call places anymore, like KPH or anyway. I just give up on it because I just can't take it. And we're not getting help. And as Dr. Nemad said, where's the forum for us to speak about these things so they can? Why do we need to be security managed? We're not as straight to the hospitals. Why, doctor, if you say that you are a minister, they will let you in, I'll take her at night. But they turn us back because you have to go through and get a pass and then join a line. No. See, what's that? So anyway, that is my beef with the system.
Right. Thanks, Garth. And yes, we have to present some of the beef, but at the same time, you highlighted that what she presented, the holistic working together, we want that. Dr. Anna Brown Morgan, we would like you to give your thoughts on it. And then I'd like, I see Dr. Julia Rowe Porter, for example. I don't know if she'll be willing to share as well. And of course, Dr. Davidson. And I think Prof. Marvin may have wanted to say something. So we have a little time, but go ahead, please, Anna.
Right. So I lead with Dr. Davidson's comment that we're a part of the future, and we're definitely a part of the future. And I guess my question there would be when will this future be adequately available? I did at one point in time, there was a process out there, and where they were asking for persons to join, to become the ministry, to establish this public partnership, medical access to the Jamaican population. My comment is that it at the time, this was pre-COVID, it would seem to have been a token event. I am not sure to what extent the actual public-private partnership exists at present. The original application process was very aseptic, I call it, and seemingly distant. We were asked to fill out a document and drop it off at, I forget the venue in New Kingston. A lot of family doctors were not even able to participate because there was a deadline and there was a requirement for a TCC, which a lot of practicing doctors don't need to have, and so they would have had to, at the time, apply for them, and some of them didn't know how to, and there was a wait time, and there was no interview process for these doctors to determine whether or not they, to talk with them, to do a screen. So how were persons chosen? And then we hear that they were, or I read, there were very few people chosen, 15 for the entire country, 15 family doctors, GPs, out of 1,000 plus, to serve these wide patient numbers, communities in which we are all based. It seemed almost, I don't want to comment, but the word would be, it's ridiculous. There's no way that those demographics could work. And we haven't heard anything more since then about this public-private partnership. There are thousands of GPs throughout all the parishes, and it is my understanding that only 15 have been signed or were signed to participate. I was wondering if this number has been increased and what is the status at this point in time, what real effort has been made to include the private GP or primary care sector of individuals. It seems that this is a kind of blind area. I think, too, this is one of the reasons why the uptake of the COVID vaccine was so poor in Jamaica. The launch of the vaccine was entirely initially about the public clinics and the drives. When it became obvious that the messages were being countered by anti-vaccine groups, the need for private doctor intervention who have a close relationship and a trusted relationship with their patients as a way of improving vaccine uptake, which had been ignored, was in the end a part of the promotion, but it was too late. It was too late for us to, the anti-vax message had taken hold, and therefore we had our 30-something%, the worst in the Caribbean, uptake. And I think that the general practitioners really could have been utilized so much more in getting this message through to their clients, their patients, and in a way in which they would trust us rather than trusting the anti-vaxxers. So GPs also have a very hard time competing with the public facilities, as in addition to having to pay the GPs for their service, the patients have only limited access to the NHF. There are no prescriptions that are free, whereas for GPs, whereas in the public sector, all prescriptions are free. So this has set up a real problem with a competing system rather than a merging system. The governments in the United Kingdom and Canada have found a way of including their practicing GP services in the communities with the care that is the medical care that is being given. And but this entire issue, it's been silent. We don't know, it could have been backbenched. Yet our GPs are suffering because of this. Many have had a decreased patient load, decreased income, even as increased fees associated with practices such as the new fees associated with the Data Protection Act, the cost of all new equipment and medications to stock at your practice. So much needs to be done to utilize this large group of individuals, trained individuals, highly trained individuals, many out there, who just wonder if they're being left behind. At this time, the public-private partnership seems almost dead. And we just need that encouragement, more information, and regeneration, just a rebirth. The GPs form a significant number of the doctors serving Jamaica, and our patients would be so much better served if the Ministry of Health would include a bit more of these doctors, more than 15, in its public-private plan. This thing seems to need to be real and not token, because the number 15 is barely token when you really look at what is required in our communities. So I'd just like to encourage the ministry, please, to look back at this public-private partnership, and to remember that there are so many doctors within our communities that they need to utilize, and that we need to be remembered. And as Dr. Garth Rashid said, we need to be respected, especially with access, when we're looking for access. Thank you.
Thank you, Dr. Anna Brown Morgan. And you highlighted so many significant points. The whole business of how do we become part of the future? And can I say this is where the future is really the past, because it was Dr. Winston Davidson who at a meeting in the Ministry of Health and several times said that when they were introducing the NHF, primary care should have been the target at that time. And he suggested that the primary care physician would be partially subsidized, just as drugs are subsidized now, by the NHF. And, the point that Dr. Dave Tamu made, though, the importance of standards, making sure that there is consistency between the doctors, can be taken on by the CCFP. Now it's 1 minute to 2 o'clock, and I hope Dr. Ishtar is not in the UK, because that means it's almost midnight. Well, no, not so bad, but it's quite a time away. So I really want to give some time for Dr. Tamu to respond, or I see other persons from the Ministry of Health. So is Tamu, yes, you can go ahead, or if Dr. Shores or Roe Porter here would like to speak, can you go ahead?
Yes, perhaps Dr. Roe Porter wants to go more into the immunization, one of our essential programs, just to talk a little more about the immunization program. And I do have some questions for the panel as well, but I will I'll facilitate her going ahead. Thank you. And then I'll give my question, pose them at the end. Thank you.
Dr. Roe Porter, go ahead.
Hi, good afternoon, everyone. Can you hear me?
Yes.
Okay, sorry,
Yes,
I can't turn on my, I'm so sorry I can't turn on my video because my internet is a little unreliable. But I want to thank you for asking me to participate, and Dr. Davidson did quite an excellent presentation, giving that overview. And what is clear is that the patient has to be at the center of public-private partnership, not just clinical outcomes, but their perception and their acceptability of the services is critical to ensure that our services are meeting the targets, are achieving the objectives that we have and meeting our goals, even in our Vision 2030 plan. So that is important to note. No, I also note the challenges and the inadequacies that were shared from our private partners, Dr. Nemmer, Dr. Rattray, Dr. Brown Morgan, and we acknowledge that the system does need strengthening. But I want to use this opportunity to share a prototype that works in terms of a public-private partnership. Dr. Davidson mentioned immunization, and I'm the National Immunization Manager. And I'd like to share in this forum that for 2024 and for 2023 as well, our vaccination coverage has been excellent. We've met our targets for most of our antigens, which is over 95%. And for last year, we would have achieved 99% for most of our antigens. For MMR, it's not where we want it to be. It's 94 for the first dose and 93 for the second dose, but it has improved significantly. And the reason why I bring it up, yes, I know this is a forum focused on elderly health, but I'm bringing it up because this achievement would not have been possible without partnership with our private sector, because we know that not all our children come to our public facilities for vaccination. So this is a prototype that is working in terms of that public-private partnership. And I think the strength of it is that it is the private sector partnership is operationalized through our health departments. The truth is the ministry, our role is policy, guidelines, quality assurance. We're not service delivery. So when we implement a service delivery program, there are going to be gaps if it's left to the ministry leading a service delivery program. So it's something that we do need to explore in terms of an approach with respect to our other target population, our elderly and other target groups other than children, because we know that public-private partnership does work with immunization. So perhaps we need to explore how we strengthen the relationship with between our private doctors and our health departments. I know for immunization, they have an excellent relationship and reports are made. Hence the reason why we can report our vaccination coverage being so high. So there is scope for strengthening the relationship of our private doctors and our health departments and our regional health authorities as a service delivery authority. I also had the experience of engaging with a parish. There's a particular parish, I won't call the name of that parish. I had to do a presentation in that parish recently. And the medical officer of health, who you all should be best friends with, as the technical lead for the services, the primary care services at the parish level. This particular medical officer of health has regular meetings with the private doctors in her parish. And it was because of that existing mechanism that I was invited to present. And I want to put it to you that a parish that does that will have stronger service delivery outcomes because the partnership is so strong through the health department under the leadership of the medical officer of health. I want to address the issue with IPV that Dr. Nemard had brought up. Now, we do provide vaccines to the to private doctors for vaccination. The problem with IPV is that, well, first of all, we have targets in terms of the population that we vaccinate. And we acknowledge, especially in the corporate area, a demand for IPV for persons that are migrating. And we are aware that private partners have been requesting additional doses of IPV to vaccinate these adults that are going away to, they're migrating because the US immunization schedule is really all IPV, there's no oral polio, versus our schedule that is a mixture of IPV and polio, oral polio. We are constrained to procure additional doses for persons that are migrating. We'd have to explore what the real demand is. But the truth is, the vaccines that we procure are for our population and the protection of our population. And there's no deficit in the schedule that we have because we are covering for polio immunity in our population. It's also important to note that adults would have gotten trivalent oral polio, and anybody that got trivalent polio before April 2026 would have full immunity for all three types of the polio. So IPV really isn't necessary. So the question is, if vaccines are needed for migration, then there really needs to be some private source of vaccines like IPV for this purpose. But this, we can have further dialogue about Dr. Nemard and team. We can have further discussion to explore how we can look at this issue further. So those are what I have to say. And if there are any other questions, I'm happy to address them. And over to Dr. Davidson.
Right. Thank you very much. Yes, Dr. Roporter. Just to comment, in my parish, it was the we call it the doctor who's in charge of the parish who approached us, and we formed a WhatsApp group, which pretty much shares information. And Dr. Nemhard had mentioned the need for a forum. And maybe WhatsApp is not the ideal formal forum, but it is an informal forum for sharing information where doctors ask questions and they get an idea of what's happening in their parish. So let's not dismiss the informal forum. Dr. Tamu, you said you wanted to ask some questions, but I would like you to address the issue of forum and whether you could, if there is a directive to your parish doctors in charge of the parish, you know, to make an effort to reach out to the doctors in their area. And secondly, in terms of consistency of standards, are the standards or protocols, as doctors have said before me, are these available, and can we create forums to share them?
So we do have protocols and standards widely available. Certainly each program unit or lead will do their dissemination through the region and the parishes at operational level. But we also have existing partnerships. So for example, Dr. Brown Morgan sits on the National Committee on NCDs, and we do webinars at the national level where we share and engage both public and private to get on board. However, I do hear in general what I got the feedback is, what is the forum, the platform, the need to have a uniform platform where you can share your concerns, you can get a quick response, and a standard. So one of the things is sometimes we do not get onto your calendar early for us to like do a workshop or collaborative workshop. So we have to, and sometimes we do have resource constraints. So we have been doing webinars, and I want to thank Dr. Brown Morgan, because I know it is through your network where we have had at sometimes 300, 400, 500 persons coming on board. So we can actually, we track who comes and where they're from. as well, because we're ultimately trying to get both public and private, disseminate that. The NCD unit and the Ministry of Health as well, we have our own platform where we do have our guidelines and our resources. So as they become available, we make sure they're publicly available. And one of the things that we're doing this year is to have online courses. So once we have a guideline, we're going to have self-directed modules, online courses, so we can advertise them. Anyone can log on, get the CME, and complete the course on that particular guideline. So we're working on 3 this year. We're looking at diabetes, we're looking at hypertension, and we've done one on screening. So we have that platform. But outside of that, my question is, how would you want to be engaged? What do you think would be the most appropriate platform? You know, you have your solutions. I heard very passionate about the platform. How would you want it? Feedback, we want to know, how is it best? Because we're always wondering, we do a lot of surveys and our doctors tell us we want to prefer that you reach us 8 o'clock in the morning rather than in the afternoon. But we also are want from you that type of feedback as how best to engage you and what sort of platform would you want to be in, because we do have many representatives from the associations in different committees, stakeholder working groups that may not be necessarily known publicly. But for Dr. Rattray here, he's in his office. How does he get his matter resolved? But what we would like to know is, what is the best way to reach, how you think would be best? You mentioned the WhatsApp was a good thing, but probably not best appropriate. How would you want to be reached? Over to you.
I would like to say something, Doc.
That's my question.
Dr.
How would
Davidson.
you want to be reached? Yes.
I want to make an effort to try. I think we need, first of all, I want to say thank you so very much for the opportunities that have been provided by you to learn about the NCDs. You have provided some seriously wonderful webinars, and I have done my best to attend many of them. So I thank you for that. Very, very good for the persons, for the general practitioners. But I think that we need to also establish a forum where we meet, not just learning about NCDs, but where you have like a meeting and invite invite the general practitioners to come, and it's a business meeting where we sit down, where we discuss the things that concern us, not just in a half-hour segment, but in a morning, 3 hours. We sit down and we really talk, and we feel that you understand and that the ministry understands these matters we're talking about. Because when we heard initially that of the public-private partnership and that doctors were going to share in the treatment of cases, that doctors were going to be included in seeing these patients, that and that they could refer within the facilities and so forth, the government facilities, and be a part of this system while seeing other patients. It seemed like a wonderful seed into a new way of practicing medicine in Jamaica, but nothing came of it because, you know, we are here, but we need to be engaged. We need to be engaged. The ministry needs to engage the doctors. And we need to start over, because it's been 5-6 years, nothing much has happened from that point of view. From the point of view of NCDs learning, I think that has been fabulous. But from the point of view of actually integrating the GPs alongside, it's not easy. It's not going to be easy. But you had promised to start, the minister had promised to start, and then we are nowhere with it. So I don't know if what Dr. Rattray might have to share on his experience with that, why he thinks it went nowhere.
Dr. Rattray?
Okay, so I'm going at a different angle. For me, it would be good to know who you can communicate with at the ministry. I used to have friends that I could communicate with, and I'd get answers and help, but it was like an individual, not a policy thing for the entire ministry. You know what I'm going to do today? Put a challenge out. I'd like for the ministry to give us access so that if you go to a hospital and you have your ID, MHA ID at the doctor, security guard don't tell you, you would not understand what I think messed me up enough. you would not understand. It's a long story, but I truncated it. Go and join a line. This line was a crowd. I just went home and and then trying to call about a patient in hospital recently in Spanish Town. If he had chest physio, he'd still be alive. He just sat there, lay there, and just died from pneumonia. I wrote about it. I was beside myself with anger. You can't pick doctor. You can't communicate with them. I'm putting this out in ministry. Go ahead and make their policies that if you're a physician with an ID and you go to a hospital, I'm talking about midnight, only nurses can say to you, well, they can't come on the ward now, doc. A security guard shouldn't be stopping me at the gate and turn me back or tell me go and join a line like anybody else. Also, we want access to patient information. Get us notes when they're, discharge summaries, or somebody can communicate with when a patient in hospital. We can help, there are things happen that the doctor didn't know. They gave them this, that, but you can't take that. We didn't know. Well, I've said, you understand, you're all doctors, right? Do that, and I don't know if it's serious or not. But that is my thing for today. Do that, and I don't know if it's serious or not.
Can I just say, though, the patient is the best vehicle. Why is the patient in your office without the referral or discharge form? And that's a protocol that needs to be put into the hospital and monitored. Dr. Nemha, looks like you're ready to say something. Go ahead, and then I'm winding up.
Right, if I may. I share the distress that Garth is expressing. The statistic keeps being presented that public health or primary care takes place 50% in the private sector. I don't know if anybody coming out of today's meeting, even with the discussion we've had from the members of the ministry, feels like they have a voice that equates to the contribution which we are set to make. I certainly don't feel it. I certainly don't feel that 50%. I don't feel the forum, even despite us saying this on more than one occasion. I don't feel that there's a forum that is going to be developed that's going to address the issues which are long-standing. I used to work in the ministry. I used to work as a medical officer of health. I know the system on both ends. This is not new. A lot of talk has been made about the partnership. I don't feel a partnership exists, and I'm not sure what it is that it's going to take for us to cross that line, whereby that 50% contribution, which keeps being presented, really becomes recognized and gives us some voice, some forum to be true contributors to the system. That's just my view at this point.
May I suggest that certainly at the ministry level, there could be some representatives from our group, private groups, that may meet on I know they must be tired of meetings, but at least some kind of coming together, maybe that same NCD meeting, to see how just using NCDs, which is the primary cause of death here, which has the greatest significance in terms of our healthcare, I think, certainly among adults, let's consider getting some kind of discussion as how we can create that forum. Dr. Tamu, go ahead, please.
Yes, thank you. And I've noted these suggestions. How about having a standing item on one of your meetings for the Ministry of Health and Wellness, standing that, to address the concerns in a meaningful way in your meeting? I think that could be one of the steps. And, one of the, for the year, one particular meeting would be hosted by the Ministry of Health. Reach out to the Ministry of Health to host one of the meetings for the year. And that's where, at least, you will get updates, the exchanges that you need, even one meeting for the year, but to have a standing agenda, even on your agenda, and our concerns with respect to Ministry of asking Ministry of Health, can we have a representative to come to our standing meeting who will address our concerns as a team, as a
Dr.
wide group.
Davidson,
So
meet with us. Have us to
recommendation.
these venues in person where we can really talk, not just where we can meet, and we have a couple of your governmental MOH, Dr. Julia, everybody. Come, let us be family and let us talk truth and let us feel that involvement. Because that is what we need. We need to come on board. And also I noticed Dr. Dane leave his hand up a long time.
Yes, please. Go ahead, Dr. Levy. Dr. Ishta, we're coming. I'm giving Dane, please, 3 minutes.
Dr. Levy muted.
Yeah.
To write prescriptions, and they were honored under the Drug Serve program, a program that can be easily monitored so that it is not abused. I wonder if that isn't probably one of the most efficient ways to improve our cooperation at this time, by returning to that system where we allow prescriptions written by the private physicians, that the patients who are in the public system are able to fill those prescriptions through the Drug Serve program. I think that's right. That should be easy to arrange and would enhance cooperation and would show that there's a real attempt being made to incorporate us into official way of official part of the patient care, and I think would restore some confidence in the system. Any one of the panelists can comment.
Because we have limited time, Dr. Tamu, please note that someone had written in the chat that we are, as practitioners, we're losing patients because patients are going to the health centers just to get free drugs. And there again, your burden is going to increase. So I think Dr. Levy's comments are very apt. I'm going to wind up. I have to take moderator privilege because we do have Dr. Govia. And I think we're going to need to do, just finally on Dr. Anna Browns-Morgan, we need the small group meetings, the person-to-person, face-to-face, but that can't include everybody. And we're trying to reach as many practitioners as possible. So yes, I'm suggesting CCFP take up that offer where once a year at least, the Ministry of Health gets to come in and have that kind of visibility.
Dr. Pauline Williams-Green, this is bigger than any one medical group of private practitioners. This is the communities, the doctors, and they're in all of the associations. And that is why this is a good venue to have that discussion, because this is the World Family Doctor Day, where we try to unite all the various groups. And so this would require leadership members from all the groups to have this discussion, because, for example, AGPJ is a source of, that's like the, what you call it now, the, where people go to find, moderate your prices, and so forth. They're almost like a union, not a union, but, those sort of representatives. They represent those ideas that would come up. And so that's very, very important.
We need to include all. And maybe for World Family Doctor Day, we can always make sure there's a forum there, for an hour. We make sure we include that private public aspect. All right, so thank you all so very, very much. Dr. Tamu, we're going to follow you up, as well as some of the points made by Dr. by the doctors in our group. I don't want you to feel it's just a chat session. I think we should have some kind of follow-up on this. And so I'm hoping to see it by the groups which are involved in World Family Doctor Day. All right, so we're now going to go on to our second point. So I want to thank every one of our panelists as we welcome Dr. Ishtar Govaya. And to our next topic, which is not public-private partnership, but it is public-private partnership, because Dr. Ishtar Govaya is very much focused. Her passion is building mental resilience in a changing world. Sorry, that's her topic. But she has a worldwide reach, and she has worked at the university and has had relations with the Minister of Health. We know her best, perhaps I do, certainly, for work with dementia, but I know her work is much larger than that, as Amaji. And you know what, Dr. Ishtar, you're much better at explaining what you need to say. So I'm going to ask you to go ahead and present on building mental resilience in a changing world. Thank you so much for your patience.
My pleasure. Can you just confirm that you're seeing my full presentation mode?
I am seeing, yes.
And not the rest of my desktop, right?
No, I'm not seeing your desktop.
Okay, super. Well, thanks so much, Pauline, and thanks so much to all of you colleagues for welcoming me again. I thought that the panel discussion just now was so imperative to what we need in terms of advancing patient-centered healthcare, as you were speaking about. And as you said, Pauline, it's really at the intersection of a lot of the roles and responsibilities that I have had with, for example, ranging from WHO with their brain health unit to working in academia and now as an entrepreneur myself with Amaji. So today I'm happy to speak with you about building mental resilience in a changing world and really the role of primary care in doing this. To reiterate some of what's been said and to really bring home the significance of what we're talking about in terms of older populations, aging populations, and the significant importance of this for the Caribbean. In Latin America and the Caribbean, we are the world region where we have the fastest transition for people who are 65 and older to go from representing just 10% of the population to representing over 20% of the population. And the truth of the matter is that by the next 3 decades plus, we will be the region of the world where 1 in 3 people will be 65 plus, and we will be the first region of the world where that is going to be happening. So the Caribbean, we are a region that is aging faster than any other region of the world. People are living longer, but not healthier lives. And we are at a very unique type of intersection where we're growing old as a region, but we're not yet achieving high income. And that puts enormous strain on health and care systems and general economies of countries. And as you know, the Caribbean region is already a very, very vulnerable region in terms of its climate conditions and in terms of its vulnerability to those types of issues. Very important to also recognize in the context of thinking and talking about resilience is the reality that there is a large number of years that the majority of persons who are 65 and older will be experiencing. And there are a few commonalities in terms of this functional dependence, in that functional dependence increases with age, and that it's women more likely than men to be showing this functional dependence. And that gender gap actually increases with age. So as women and men get older, it's more women that are showing this years of disability, this functional dependence. And also it is really a serious issue that we're confronting, particularly with those that are most vulnerable, those that are at the lower ends of the socioeconomic spectrum. And given the discussion that we were having just now about the transitions and the moving between these sliding doors of public and private, that we're seeing a lot of our patients, a lot of our clients experiencing, we really need to figure out how to get this right. And we really need to figure out how to get this right, because what we're seeing is that care dependence is increasing. As you'll see from this figure here from an IDB report, there is a quarter of the population in Mexico that is reliant on care, a quarter of the population of those that are 65 and older. And when you look at this for example, Jamaica, you see that that's close to 17% of those that are 65 and older that are care dependent. You see the range here, and it is in the high levels, approaching 20% of the population of those that are 65 and older. And as we were talking about today, we're all getting there. We're all moving up in age. And so it's really important to be thinking about and preparing our services and systems to deal with these. So IDB has presented us with a challenge, and it's presented us with as well a framework and architecture to deal with these realities that we're facing. And they've suggested that we plan for the creation of an entrepreneurial ecosystem to handle this aging population and the needs for long-term care. Because as we know, long-term care services range in quality, range in their ability to be regulated, and range in their accessibility. Those that are really at the high end in terms of the service quality are not accessible and available to the vast majority of the population. And so they have presented us with a number of opportunities to really work and plug into an entrepreneurial ecosystem, including things like training courses, including things like certification of skills for caregivers, training centers, digital portals to collect demand and supply, and really thinking through things like private financing as well. And I mention that because I'm telling you about today as part of the discussion, some of the initiatives that Amaji as a social venture is really embarking on as part of this entrepreneurial ecosystem. And what specifically do we mean by a social venture? A social venture sits at the middle ground of a purely charity-focused entity and a purely for-profit entity. And so a social venture is that middle space where we are doing, it is a for-profit company, but there is a certain level of lockedness in the articles of association that are specific to the purpose for which that organization has been created. And Amaji has been created to address the treatment gap in brain health and dementia care. So how do we facilitate resilience? And how particularly is Amaji doing this, for example? If I asked you what is the percentage of the impact of health care on health, what would you say? What do you think is the percentage of the impact of health care on health? Hazard a guess. Some people might think that it's closer to the 80%. Some people might think that it's closer to the 100%. The reality is that healthcare is less than 10% of what really matters in terms of our health outcomes. And the rest of it, in terms of where health is created, as you can see, is about your postcode or where you live, the circumstances that you're living and breathing and moving, working, playing in. The others are behavior, lifestyle, and the options that your environment gives you in terms of your behavior. So if, for example, you don't have access to green spaces, to walk safely, if you don't have access to healthy food, then your behavior is going to reflect those environmental conditions and circumstances. And that's where it's really important to think about modifiable risk factors. And when we think about brain health and resilience in brain health, we really are zooming in on this Lancet Commission, which was recently updated at the end of last year in terms of the modifiable risk factors, and particularly interested in the ones that are within the individual's control. And today we talked about a large number of those, from diabetes management to hypertension management, cholesterol management, hearing impairment management, vision impairment management, and also addressing things like depression and loneliness. But there are some that are also environmental. So air pollution, for example, and exposure to toxins in pesticides in terms of your environmental moles. And these are the ones that we really need to be thinking about. How does this translate to you in your primary care practice? What it means is that we really need, as some of the other presenters have said, and some of the panelists just now were speaking about, we really need to take a person-centered approach to our care, whether that is somebody that is officially a patient in the healthcare system, or that's a client in terms of some of the other services and offerings that you offer and that we offer. And there are tools that exist to help us do this. And I've shown you one here. If you would like this resource, do contact me after. It's also important to build cognitive reserve. And building cognitive reserve means recognizing that your brain health is a function of a number of domains. It's related to your motor functioning, your sensory functioning, your tactile function, and your emotional function, in addition to your cognitive function. And often when people think about brain health, they immediately go to cognitive function without understanding all of these other elements that are crucial to brain health. And so building your cognitive reserve, which happens from the moment of birth onwards. And so this is why it's crucial that we take a lifespan and life course approach to things, is really important in terms of zooming in on the domains that matter for our cognitive reserve. What can we do in primary care? So in primary care, whether being delivered in public or private, we can really try, even though there are massive limitations in public health care, primary care delivery, as we know from talking to our colleagues who are working in these clinics, in these spaces, the limited time that you have for the appointments with your patients, the stretched human resources, the limited technological infrastructure, all of these things really place a lot of challenges and can really contribute to disparities in the quality of care between public and private health in primary care. Wherever you are, though, there are a few things to focus on, including things like social connectedness, cognitive stimulation, chronic disease management, and emotional regulation and caregiver support. So how can you do this in terms of some practical strategies? So one, you can take some micro moments for cognitive care. You can do resilience check-ins during your routine visits. You can focus, for example, on what you, from your work with your patient population, your client population, have been able to track as the most important modifiable factors on which to intervene. So some of the key ones that we keep hearing popping up are including sleep, a lot of persons with sleep apnea, memory, and support systems. And there are tools that exist to help you do this, to shift your attention from crisis management to intervening as a challenge is starting to percolate. Also, prescribe connection and purpose. There are systematic reviews that demonstrate the significance of social prescribing. And social prescribing, meaning that you are linking your patients, your clients, to different types of services and to activities that can actually enrich their physical, emotional, and cognitive functioning. So also promote volunteerism, also promote things like caregiver circles. And then also practically leverage an interdisciplinary brain health network. So with our Brain Health Navigator training program, we are seeing GPs doing this. So one GP in the public sector in St. Anne, for example, is developing a structured physical activity program, which has some other intervention components and really is gearing towards enhancing brain health, reducing isolation, and supporting chronic disease management. A GP in the private sector in our Navigator training program is focused on women. What she's recognized and what we know from the literature is that dementia, specifically Alzheimer's disease, is much more prevalent among women, and that women face particular risks across the lifespan, from pregnancy to menopause and all of these different processes in between. And so her intervention, her focus, her training is really equipping her to design tools that will help her to improve dementia risk reduction and dementia prevention with this particular group. Are you actually providing aging sensitive care? And if you are, we would encourage you, because this is a repeated issue that we hear practitioners talking to us about, is where do I refer to? So what we would say is add yourself to the directory. It's a free directory. Add your practice to the directory, and also refer patients or clients who need support. We have a professional referral form that you can use if you click on the care on Amaji's website. And there's also a form, a care enquiry form, that persons who are caring for older persons or just interested in themselves, their own cognitive functioning, their own brain health functioning, they can fill out. Be part of building the Caribbean brain health ecosystem. We already have some key partners. I'll be really happy once we add CCFP, AJP to this list of key partners in terms of building out this ecosystem for care. We are also building out partners in other Caribbean countries as well for different pilots. We're following up in terms of care services for persons who are involved in research projects that we had led in the past. And then we also encourage you to save the date for the Caribbean Brain Health Summit. It's the first summit of its kind for the region, and we're doing this in Jamaica next year. So if you are wanting to build resilience and you want to be a leader and change maker in brain health and dementia care, or if you know somebody who does, who you think is really a future brain leader, a change maker in this space, whether in public health or private health, we encourage you to identify them. We encourage you to signpost them to this training. Our next cohorts are starting in September this year, in January, and in April next year. And our training works in terms of, it's very small. We cap it 10 maximum per cohort. We have weekly live sessions, personalized advising. They work on a practical clinical implications, public health implications capstone project, and they are equipped with a lifetime access to relevant tools and evidence. So how else can you build resilience for and with your patients and your clients? You can really focus on strengthening your risk identification and risk management screening. There are a number of tools for this. You could conduct cognitive screenings yourself. We can assist with training you to do that. And you can really clarify, and I think this really speaks very strongly to that discussion we were having on the panel just now. You can clarify which patients or clients need referrals and link them with supports. And it's important to do this across both public and private sectors. So I want to just thank you again for having me be part of this celebration of World Family Doctors Day. I really am grateful for the continued collaboration with this community, and I'm looking forward to building practices with you that enhance and build brain health resilience. Thank you so much.
Thank you very much, and thanks for your understanding as we carry through. So we have come to the end, and we're going to hand over to Dr. Donald Gordon, who will give the vote of thanks. Thank you for the privilege of participating as a moderator.
Are you hearing me?
Yes, we are, Doc.
Oh, thanks very much, Pauline, for introducing me. I must say, thanks to all of our listeners who have stayed tuned to this excellent WFDD production. First, thanks and a happy World Family Doctors Day to our listeners, speakers, sponsors, the CCFP administrators, and the whole GATE technical team. Much thanks to our opening speakers, Prof. Marvin, Professor Karen Carpenter, Professor Elmire Shearer, Doctors Victor Elliott and Dr. Marcosan, Dr. Kian Bukal, Dr. Ishtar Govaya, who all spoke so eloquently and knowledgeably on the challenges, vulnerabilities, and drivers of morbidity and mortality in the aging population. And also thanks for the valuable information given, for the intervention in terms of preventing and ameliorating the effect of aging. Also, thanks to our valuable sponsors, Indus Life Sciences, About Nutritional Products for their wide-ranging products for the different age groups and medical condition. A very special thanks to Dr. Ferrario and the GSK for their support and the highlighting of the role of vaccine in disease prevention in the older population. Can't overemphasize the importance of vaccination against shingles, COPD, pneumococcal, etc. Shingles in particular can cause severe morbidity in the elderly population whenever they contract it. Thanks to our panelists who took part in the discussion on the public sector and private sector partnerships. Thanks to Dr. Tamu Davidson, panelist Dr. Orville Nemard, Gard Rattray, Dr. Anna Brown Morgan, for highlighting the cooperation and the gaps between the public and the private sector partnership. Very special thanks to our moderators, Dr. Aileen Standard, Dr. Monica Aznani, Dr. Pauline Williams-Green, for their skillful moderation in helping us to keep to our time schedule. Finally, I must say special thanks to Dr. Pirai for our opening prayers, Dr. Seni and Dr. C and the CCFP, and Dr. Arna Morgan for giving us that very inspiring talk on the CBRJ, and also for our role in the organizing committee for doing the heavy lifting in pulling off another successful World Family Doctor Day. Thanks to Sam of Oldgate Solutions and Lenny of CCFP ABJ for the flawless execution in bringing all the participants in an excellent production. Finally, thanks to CARMED in their unwavering support in providing gift baskets over the year for the past 10 years to our speakers in helping us to pull off these wonderful World Family Doctor Day. And my final thanks is to the committee who worked so hard in making this a successful presentation. And back to you, Pauline.
Thank you very much. And I would like to wish you all a wonderful World Family Doctor Day celebration. Look at the chat. Dr. Govaya is answering some of the questions that were posed as well. Really want to thank all the participants and the committee, as Dr. Gordon highlighted. Have a very good afternoon. I'm sure it's time your families wanting you to come back and join them. Have a wonderful day. Thank you.
That is constantly evolving, our mental resilience is put to the test daily. From the stresses of modern life to unexpected challenges, maintaining mental wellness is more crucial than ever. But who stands at the front lines of this battle for our mental health?